else. Starting rapid fire with question 1. What single factor drives the highest elevated cardiac risk? Is it controlled diabetes, mild renal impairment, a TI 9 months ago, or controlled hypertension? It is not controlled diabetes, it is actually option C, a TI 9 months ago. Listen, the exam writers love trying to trap you with diabetes just because it's a famous cardiovascular risk factor. But a history of a TI or a stroke brings a significantly higher perioperative risk for major adverse events compared to just controlled diabetes on oral meds. Moving right into question 2. How do you classify the functional status of a patient who can golf with a cart and climb 2 flights of stairs, but they can't jog? The answer is B, moderate. That classic 2 flights of stairs clue? That equates to about 4 to 7 METs, which solidly lands them in the moderate functional capacity tier.
Moving right along to question 3, which looks at reducing surgical site infections, or SSIs. Option D is your winner here, maintaining an SpO2 greater than 96%. Why? Because adequate tissue oxygenation is literally vital for SSI prevention. But look closely at the traps in the other options. Please, whatever you do, don't fall for the shaving trap. You always clip, you never shave, because shaving introduces micro tears into the skin, which just invites bacteria in. For question 4, we're evaluating recurrent venous thromboembolism, or VTE risk. The highest risk patient on the board is option C, a patient with a VTE just 4 months ago who also has protein C deficiency. The pearl you need to know? Protein C deficiency is a high-risk thrombophilia. Combine that with a super recent VTE, and you've got the ultimate high-risk scenario for recurrence.
And this brilliantly illustrates our point for question 5. Which patient with a prosthetic heart valve is at the greatest risk of perioperative thromboembolism? It's option B, an asymptomatic patient with a mechanical mitral prosthesis. Look, exam writers are going to try to distract you by mentioning a history of stroke or AFib in patients with an aortic valve, but remember this rule. A mechanical mitral valve inherently carries a much higher thromboembolic risk than a bileaflet mechanical aortic valve. Don't let the distractors pull you away from the valve type itself.
Let's unpack the vignette for question 6. Who actually needs a pharmacologic stress test before surgery? For this one, you want option C, a diabetic undergoing peripheral arterial bypass whose claudication limits walking. Why this specific patient? Well, because they hit the absolute triad of risk. They're undergoing a high-risk vascular surgery, they have cardiac risk factors like diabetes, and critically, they have poor functional capacity. Their claudication literally prevents them from walking on a treadmill. Because of that, a conventional exercise test is useless here. You absolutely must use pharmacologic stress testing.
Sprinting into question 7. This is a simple recall fact, but you gotta know it cold. For an elective operation, how many days prior should Coumadin or warfarin be discontinued? The answer is 5 days, option C. It takes exactly that long for the existing clotting factors to clear out and for the liver to synthesize new ones. Warfarin equals 5 days. Next up, question 8 asks for an indication for postoperative hemodialysis. You'll want option B here, removal of fluid in an intubated and anuric patient with pulmonary edema. This triggers the O for overload in your AEIOU dialysis indications. A high creatinine alone? That's a total trap. It is not an indication for dialysis on its own. Refractory fluid overload with respiratory compromise absolutely is.
Wrapping up Chapter 1 with question 9. You have an emergent laparotomy that lasts 5 hours with 4 liters of fluid given. When should the Foley catheter be removed? The golden rule here, which is option B, is removing it on post-operative day 1. The exam pearl is all about reducing catheter-associated UTIs. You remove it as early as clinically appropriate. Listen, exam writers want you to think a long surgery or tons of IV fluids justifies keeping that Foley in for days. It absolutely does not.
All right, great job keeping up. Now we are shifting gears into Chapter 2, Postoperative Problems, Part 1. We're going to take a deep dive into the first 7 major complications you're going to see in the hours and days following surgery. Now, what's really interesting about this slide is just how commonly these concepts are tested on the boards. Question 1. Postoperative oliguria with a fractional excretion of sodium, or FeNA, of less than 1% is most consistent with what? Option A, prerenal acute renal failure. A FeNA under 1% means the kidneys are desperately holding on to sodium because they sense decreased perfusion. Okay, question 2. Which is not an appropriate treatment for acute delirium? Option B, benzodiazepines. Guys, this is a massive exam trap. Benzos generally worsen acute delirium and you really should avoid them. The only major exception where benzos are the answer: alcohol withdrawal. Let's unpack the vignette for question 3. An otherwise healthy guy is 16 hours post-op. His urine output drops to less than 15 cc's an hour, and his heart rate bumps up to 102. What's your immediate next step? The answer is G, which combines measuring hematocrit and giving a 1-liter fluid bolus. The clinical pearl to take away here: early postoperative oliguria combined with tachycardia has to trigger an immediate suspicion for hypovolemia or bleeding. You don't just blindly rush them back to the OR for a laparotomy based on this alone. Check their blood count and give fluids first.
Question 4 asks for the maximum antibiotic duration after routine, uncomplicated general surgery. Option D is your key here, 24 hours. Remember, prophylaxis is strictly capped at 24 hours. Prophylaxis is not a treatment for an established infection. Moving right along to question 5, regarding the Surgical Care Improvement Project, or SIP guidelines, which of these is not a SIP recommendation? It's option B, placing antibiotic-impregnated central venous catheters for complicated cases. While those might get used in very specific ICU settings, they are absolutely not a standard SIP measure for routine surgical site infection prevention.
Breaking down question 6, a 75-year-old female is suddenly disoriented and extremely agitated in the PACU. Your next step? Option D, vital signs and pulse oximetry. The trap here is ordering a CT scan immediately. Listen, sudden post-op agitation can very well just be hypoxia. Check the ABCs and oxygenation first. Now for question 7. We've got a delirious patient on POD1 who thinks he's hanging out in the 1960 White House. You've ordered sleep hygiene, so what's next? Instead of Benadryl, which is a trap that will just make it worse, you want option B, quetiapine. For severe, recalcitrant, hyperactive delirium that just isn't responding to non-pharmacologic measures, quetiapine is a really solid adjunctive therapy. Before we jump into the final block, I need you to lock this algorithm into your brain. The early post-op golden rule. When things go wrong, you assess, then you resuscitate, then you investigate, and only then do you reoperate if indicated. Honestly, mastering that logic will solve half the questions on your exam. Seamlessly transitioning here into Chapter 2, Post-Op Problems 2. We have 8 questions left on the docket. Let's keep this brisk, focused pace going.
Question 8 gives us a patient on post-op day 3 with a heavy history of alcohol use. He's seeing ants on the wall, sweating profusely, and he's tachycardic. The diagnosis here is delirium tremens, option C. The timeline here is a massive exam pearl you need to know. Basic withdrawal symptoms start within hours. Withdrawal seizures usually happen between 6 and 48 hours. But delirium tremens, characterized by those vivid visual hallucinations and severe autonomic instability, classically strikes exactly in that 48 to 72-hour window.
Quick read-through for question 9. The exception for causes of hypovolemia on postoperative day 0 is option E, sepsis. On day 0, if the patient is hypovolemic, you really need to think bleeding, under resuscitation, or maybe anesthetic vasodilation. Sepsis is incredibly rare on day 0 unless they literally came into the OR septic. Moving to question 10. Burn this one into your memory. Post-op MIs classically strike on day 2, which is option C. Postoperative day 2 is exactly when you need to have your highest index of suspicion for myocardial infarctions.
So the crucial point for question 11 highlights a major physiological shift. It's POD2, the patient has a history of congestive heart failure, they are suddenly short of breath, and their SpO2 is dropping to 89%. What's next? Option A, supplemental oxygen and furosemide. See, on POD2, all that third-spaced fluid starts mobilizing back into the vasculature. In a CSF patient, that causes volume overload and pulmonary edema. You manage this with diuresis and oxygen. Do not fall for the trap of blindly intubating them just because the saturation hit 89%.
All right, question 12 presents a 70-year-old on POD3 who's just starting clear liquids. He vomits twice, then suddenly complains of difficult breathing. He has a fever, but his chest x-ray is totally normal. Top differential? Option B, gastric aspiration. The sequence gives it away completely. Oral intake, vomiting, sudden respiratory distress. But slow down. The massive trap here is that normal x-ray. An immediate chest x-ray will often be totally normal right after aspiration. Those nasty infiltrates take time to develop.
Let's see how this clinical reasoning builds right into questions 13 and 14. For 13, at 6 hours post-op from a hernia repair, the patient is unable to void. Next step, option D, bladder scan. Consider Foley placement. Always scan first to check the volume. Don't blindly place a Foley for 14 days. Okay, question 14. POD2, their creatinine increases to 1.8 and the FeNA is 0.8%. Diagnosis?
Option D, prerenal failure. Notice how this concept repeats? A FeNA of less than 1% just proves its high-yield recurrence on these board exams. It means poor perfusion, not intrinsic kidney damage.
And here we are at our final question, number 15. Patients with nausea lasting more than 24 hours out from surgery should be evaluated for an ileus, which requires option E, nasogastric decompression. In the first 24 hours, nausea is usually just from the anesthesia, but past 24 hours, persistent nausea and vomiting absolutely demands NG decompression to prevent the exact gastric aspiration scenario we just discussed in question 12. And the trap here? Do not automatically rush them back to the OR for an uncomplicated ileus.
So question 1 asks, after a patient eats a large meal of carbohydrates, which of the following occurs? The distractors here include ketone formation, CCK release, muscle breakdown, and glycogen depletion. But the correct answer is B. Oligosaccharides are cleaved by salivary amylase. Now, here's exactly why. Carbohydrate digestion actually begins right there in the mouth, not the stomach. Salivary amylase breaks starch down into smaller oligosaccharides. Let's look at those distractors for a second. After a heavy carb meal, your body is in an anabolic storage state. That means you're building and storing glycogen. You're definitely not depleting it. Ketone bodies, those form during starvation, not right after a meal, and muscle breakdown only happens when nutritional requirements just aren't being met. So, time for a pearl drop. Carbohydrate digestion starts in the mouth via salivary amylase. Moving right along to question 2, we're looking at the simple starvation timeline. How long does it actually take for carbohydrate stores to be completely exhausted? Is it 48 hours, 6 hours, 18 hours, or 10 days? The correct answer is D, 12 hours. During simple starvation, your hepatic glycogen stores are basically your first line of defense, and they become fully depleted in about a 12 to 24-hour window. Once that happens, the body has to pivot, right? It increasingly uses fat and protein for energy. So remember this absolutely vital timeline. At about 12 hours of starvation, the glycogen is gone, and fat and protein metabolism takes over the show. Let's see how this builds in a clinical scenario for question 3. Picture this, like an ER handoff. You have a 21-year-old male trauma patient in the ICU with multiple rib, humerus, and femur fractures, and he's currently intubated. How much protein does he require? Well, a normal, non-stressed adult needs about 0.8 to 1.2 grams per kilogram per day. But our patient is critically ill. Because of the hypercatabolic stress response from his massive trauma, his needs jump way up. So the correct answer is A, 1.2 to 1.5 grams per kilogram per day. Now notice that if he had severe burns or sepsis, that would push the requirement even higher, all the way up to 2.0 grams. But for typical critical illness, 1.2 to 1.5 is the exact sweet spot. All right, moving up to the floors for Section 2, Assessment and Diet Initiation, Navigating Systemic Inflammation and Surgical Diets for questions 4 through 6. Question 4 presents a 45-year-old male in the ER with perforated diverticulitis. He's been ill for the last week. Which of the following is a clinical sign of acute disease-related inflammation? Your options are hypoglycemia, bradycardia, dyspnea, chest pain, or hypothermia. Now, what's really interesting here is the correct answer, B, hypothermia. It's totally counterintuitive. We usually think of a fever with an infection, right? But severe systemic inflammation can actually produce either a high fever or hypothermia. The distractors are wrong because systemic stress typically causes a fast heart rate, tachycardia, not bradycardia, and it causes hyperglycemia, not hypoglycemia. Your pearl for this one, always look for fever or hypothermia paired with tachycardia and high blood sugar. Okay, question 5 is a bit of a math challenge, so let's crunch some numbers. We have a 36-year-old female who is 5 days post-op from a cholecystectomy that was complicated by a bile duct injury. Her pre-op weight was 150 pounds, and her height is 5 feet 6 inches. So what her BMI and her daily energy needs? First things first, convert 150 pounds to kilos. That's roughly 68 kilograms. Next, convert 5 feet 6 inches to meters, which is about 1.68 meters. BMI is just weight divided by height squared, which gives us 24.2. Now, for a normal BMI range of 20 to 25, the baseline energy requirement is 20 to 25 kilocalories per kilogram per day. Following the math leads us definitively to correct answer E, a BMI of 24.2 and energy needs of 20 to 25 kilocalories per kilogram per day. Question 6 looks at diet advancement. A 56-year-old male is on post-op day 7 after a Whipple procedure. If he receives the wrong diet, which symptom might he experience? Vomiting, constipation, fever, hypoglycemia, or bloating? The correct answer is B, bloating. Here's why. After a Whipple, or really any gastrectomy, the stomach's reservoir capacity and its emptying mechanisms are permanently altered. If you rapidly deliver hyperosmolar food straight into the jejunum, it acts like a sponge and pulls massive amounts of fluid right into the bowel. We call this dumping syndrome. It causes bloating, diarrhea, and cramps. Definitely not constipation or a fever. The management pearl: stick to small, frequent meals and heavily limit those simple sugars.
Let's transition to Section 3, Enteral Access and Risks. We're looking at safe routing and refeeding dangers for questions 7, 8, and 9.
Question 7 acts like an urgent ICU consult. We've got a 47-year-old alcoholic male with a 3-day history of hematemesis. He just had an EGD showing varices with stigmata of recent bleeding, though there's no active bleeding right this second. He's in the ICU. Which of the following is a contraindication to starting enteral feeds? The correct answer is D, UGI bleeding. Let's systematically debunk those other options. Just being in the ICU, going through alcohol withdrawal, lacking established access, or having a recent EGD? None of those actually preclude feeding, but a severe recent upper GI bleed is an absolute, strict contraindication to dumping food into that very same stomach. Always remember the hard stops for enteral feeds: intestinal obstruction, severe GI bleeding, intractable vomiting, and severe diarrhea.
In question 8, a 70-year-old male suffered a stroke, unfortunately failed his swallow study, and has a history of a large hiatal hernia with large volume MSS. He needs long-term access. Should we leave a small bowel tube, do swallow exercises, use an NGT, a G-tube, or a jejunostomy tube? The correct answer is D, jejunostomy tube. But why? Well, a G-tube or an NGT feeds directly into the stomach. Given his large hiatal hernia and that history of vomiting, putting food in his stomach creates an incredibly dangerous aspiration risk. A temporary small bowel tube just isn't suitable for the long term, and swallow exercises aren't going to provide the immediate caloric intake he desperately needs right now. The only logical, truly safe choice is to bypass the stomach entirely and feed post-pyloric, straight into the jejunum.
Question 9 introduces a 55-year-old severely malnourished alcoholic who is starting tube feeds after an esophageal rupture repair. What electrolyte abnormality are you most worried about here? Hyperphosphatemia, hypernatremia, hyponatremia, hyperkalemia, or hypophosphatemia? So the crucial point is understanding the underlying mechanism of refeeding syndrome. When you suddenly introduce nutrition to a starved patient, their body reacts by releasing a massive surge of insulin. This insulin aggressively drives phosphate, potassium, and magnesium straight out of the blood and into the cells. Because of that sudden shift, the classic, highly tested finding is A, hypophosphatemia. It's a dangerous, rapid drop in blood phosphate levels.
All right, guiding you out of enteral feeds and into the complex world of Section 4, TPN composition and goals. This is intravenous nutrition in the ICU for questions 10 through 12. Question 10 requires meticulous attention. A 42-year-old female is in the ICU after surgery for a perforated ulcer. She's vented, on pressors, weighs 50 kilos, and is 1.5 meters tall. She has no renal or hepatic dysfunction. So what should her TPN composition be? Let's break it down. Her BMI calculates to 22.2, which is perfectly normal. So her energy requirement is 25 kilocalories per kilogram per day. Now what about protein? Because she's critically ill, her protein needs definitely increase, but because her kidneys and liver are functioning normally, she can actually handle the processing of that protein. The goal becomes 1 to 1.5 grams per kilogram per day. This perfectly aligns with our correct answer B, 25 kilocalories per kilogram per day for energy and 1 to 1.5 grams of protein.
Question 11 is a classic mythbuster. What is the blood glucose goal for critically ill patients on TPN? The incorrect answers include less than 100, less than 110, less than 150, or having no goal at all. But the correct standard today is C, less than 180 milligrams per deciliter. For a long time, the medical community honestly fell into the less than 110 trap. We all thought tighter control had to be better, right? Well, actually, scratch that. Extensive studies reveal that very tight glucose control in the ICU actually increases the risk of severe hypoglycemia and drives up overall mortality. The pearl here is crystal clear. Target less than 180 and do not fall for the danger of overcorrection. Question 12 presents a 6-year-old TPN-dependent male with short gut syndrome and a non-healing leg wound. Which trace element does he need? Is it manganese, fluorine, selenium, copper, or zinc? The correct answer is E, zinc. Zinc deficiency classically causes impaired wound healing, alopecia, and an altered sense of taste. And this brilliantly illustrates why you need to know the distractors too. Let's lock them in. Fluorine deficiency affects bones and teeth, not acute wound healing. Selenium deficiency leads to cardiomyopathy. Copper deficiency causes anemia and neutropenia, and manganese deficiency causes dermatitis. So if you see a non-healing wound in a TPN patient, think zinc. We are in the final stretch. Section 5, specialty diets and adjustments. We are fine-tuning for specific pathologies to round out our final 3 questions. Question 13 asks about a 22-year-old female presenting with an acute flare of ulcerative colitis. When she starts an oral diet, what is preferred? A regular diet, a high-fat/protein diet, tube feeding, a dumping diet, or a low-fiber diet? The correct answer is A, a low-fiber diet. You've got to differentiate this from a high-fat, high-protein diet. Those are meant for hypercatabolic states like major burns. Tube feeding isn't indicated if she can safely eat orally, and a dumping diet is specific to altered gastric anatomy like we talked about earlier. In an acute inflammatory bowel flare, the primary goal is mechanical bowel rest. A low-fiber, low-residue diet reduces stool volume and minimizes the physical stimulation of those inflamed bowel walls. Question 14 addresses the practical daily management of TPN. Which additive needs daily adjustment? Vitamin K, H2 blockers, copper, zinc, or potassium? The correct answer is C, potassium. You see, trace elements like copper and zinc, as well as standard vitamins like vitamin K, remain largely static in TPN bags, unless there's a specific identified deficiency. H2 blockers can be added in, sure, but they don't require daily tweaking based on metabolic flux. Electrolytes like potassium, on the other hand, fluctuate constantly based on a patient's clinical status and shifting fluid levels. They require strict daily vigilance and adjustment based on morning lab results. For our 15th and final scenario, we have a 50-year-old male on tube feeds 3 days post-bowel resection who develops profuse diarrhea. C. diff testing comes back negative. What is the right move here? The incorrect options include starting antibiotics, increasing formula concentration, adding soluble fiber, or completely switching to TPN. The definitively correct clinical move is D. Start an antidiarrheal like loperamide. Systematically, we know an infection has been completely ruled out, so antibiotics are useless. Increasing the feed concentration is a huge mistake because it will actually worsen the osmotic diarrhea. Adding soluble fiber just won't immediately halt profuse liquid output like a targeted medication will. In TPN, that is far too drastic a step just for diarrhea. Once C. diff is excluded, loperamide is your absolute best answer. Question 1. Okay, question 1. You've got a 57-year-old guy with atrial fibrillation, and his platelets drop to 60,000 at 7 days after starting a heparin drip. He develops lower extremity swelling, and an ultrasound confirms a new DVT. What changes should be made to his anticoagulation? The correct answer is C. Start the patient on a bivalirudin drip. So the crucial point here is recognizing this as heparin-induced thrombocytopenia, or HIT type 2. You know, the timing is a dead giveaway. It's 5 to 10 days post-heparin, accompanied by a platelet crash and a highly thrombotic state, which explains that new DVT. You absolutely must stop all heparin immediately, but obviously you can't just leave them unanticoagulated. So your exam pearl? 5 to 10 days, plus a platelet fall, plus a new thrombosis after heparin equals HIT. Stop the heparin and start a non-heparin anticoagulant like bivalirudin. And remember, we avoid giving platelets here because they can actually worsen the thrombosis. Moving right along to question 2. A 45-year-old male is septic and found to have disseminated intravascular coagulation, or DIC, specifically with hypofibrinogenemia. Which product is appropriate to administer? The correct answer is D, cryoprecipitate. Why? Well, because when you have a specific, severe deficiency in fibrinogen that's causing bleeding, cryoprecipitate is your absolute best friend. While fresh frozen plasma does replace multiple coagulation factors, it has a much lower concentration of fibrinogen by volume. That makes cryoprecipitate your clear-cut best choice for targeted, severe fibrinogen replacement. Your pearl for the boards is simple. Low fibrinogen equals cryoprecipitate. Let's see how this builds our understanding of bleeding disorders with question 3. Patients with hemophilia A, what is true about them? The correct answer is C. They may produce factor VIII inhibitors. So hemophilia A is an X-linked recessive disorder, meaning it predominantly affects males, and it's characterized by a factor VIII deficiency. When you give these patients factor VIII replacement, their bodies can sometimes actually develop inhibitors against it, which obviously complicates treatment. Notice the contrast here with hemophilia B, which is a factor IX deficiency, also known as Christmas disease. All right, question 4 is testing your knowledge of critical stopping points. Which of the following is not an absolute contraindication of fibrinolytic therapy? The correct answer is E, active menses. When you're considering systemic fibrinolysis, major red flags like active bleeding, recent strokes, neurosurgery, or intracranial neoplasms, those were absolute hard stops, no way around them. But normal menstruation? because it's a localized, physiologically controlled process rather than a systemic hemorrhage or some enclosed space bleed, it's actually not an absolute contraindication. That is a highly testable distinction, so make sure you've got it locked in. Next up, question 5 is all about von Willebrand disease, which is the most common inherited bleeding disorder. Which statement is correct? The answer is E. Type 3 is treated with cryoprecipitate. Let's break down the disease types real quick to understand why. Type 1 is a quantitative deficiency, and it often responds beautifully to DDAVP. But type 3? That's a severe, near-complete deficiency of von Willebrand factor. For type 3, DDAVP just won't cut it. You literally need physical replacement with functional VWF-containing products, like cryoprecipitate. Question 6 asks, which of the following concerning factor 13A is correct? The correct answer is B. It is involved in the cross-linking of fibrin. Factor 13A is quite literally the fibrin-stabilizing factor. It takes those loose fibrin strands and cross-links them together to create a rock-solid, stable clot. Remember, it is not deficient in Christmas disease, that's factor 9, like we just talked about. So your memorization pearl here, factor 13A equals fibrin cross-linking, which equals a stable clot. Now, question 7 poses a classic board trick. A deficiency of all of the following will result in hypercoagulability, except the correct answer is A, prekallikrein. This brilliantly illustrates a somewhat counterintuitive medical concept. Protein C, protein S, antithrombin 3, and plasminogen are all natural anticoagulants, so missing them naturally makes you clot more. But prekallikrein, that's part of the intrinsic coagulation pathway. A deficiency here will definitely prolong your PTT on a lab test, but it actually doesn't cause a hypercoagulable state, or even a significant bleeding tendency for that matter. The takeaway, a prolonged PTT does not always mean a bleeding tendency. On to question 8. Which of the following is correct regarding antithrombin 3? The correct answer is A. It is a necessary cofactor for heparin. You see, heparin doesn't just work on its own. It exerts its massive anticoagulant effect by binding to and activating antithrombin. Once activated, antithrombin then goes on to inhibit thrombin, which is factor 2A, and factor 10A. Don't confuse this with drugs like argatroban, which inhibit thrombin directly and bypass antithrombin altogether. Following up on that exact same logic, question 9 asks about the prothrombinase complex. Which statement is correct? The answer is A. It is inhibited by heparin. To understand exactly why, remember that the prothrombinase complex is made up of factor XA, factor VA, calcium, and a phospholipid. Its entire job is to convert prothrombin into thrombin. Because we literally just learned that heparin activates antithrombin, which in turn knocks out factor XA and thrombin, it perfectly logically follows that heparin successfully inhibits the activity of the prothrombinase complex. And that brings us to our final hemostasis question, question 10. Cryoprecipitate includes which of the following? The correct answer is E, von Willebrand factor. We've talked a lot about cryo today, so let's firmly memorize its contents once and for all. It is packed with fibrinogen, factor 8, von Willebrand factor, factor 13, and fibronectin. If you ever need factors 2, 7, 9, and 10, you'd reach for fresh frozen plasma instead. So your final formula to memorize for this chapter is cryo equals fibrinogen plus factor 8 plus VWF plus factor 13. Okay, take a breath. Great job making it through the first half. Let's shift gears right into section 2, anesthesia fundamentals. We've got 7 high-yield questions standing between you and board prep mastery. Let's go. Question 1 of anesthesia. A 56-year-old male is getting an elective hernia repair under local anesthesia. Right after the injection, he acutely becomes unconscious, hypotensive, and starts convulsing. What is the correct management? The answer is D, lipid emulsion therapy based on clinical severity. This dramatic vignette is the classic presentation of local anesthetic systemic toxicity, or LAST, usually resulting from an accidental injection into a blood vessel. The management triad you absolutely must memorize is secure the airway, use a benzodiazepine to stop the seizures, and give 20% lipid emulsion. Definitely avoid propofol and high-dose epinephrine in this specific scenario. Question 2. A 44-year-old woman undergoes uncomplicated induction of general anesthesia. The minimum standards for basic monitoring include all of the following except. The correct answer is B, cerebral oximetry. Basic standard monitoring requires checking oxygenation, ventilation, circulation, and temperature. So things like an ECG, a blood pressure cuff, a pulse ox, and end-tidal CO2. Those are non-negotiable standards. Cerebral oximetry, while definitely useful in some specific complex surgeries, is just not part of the basic routine monitoring standard. Question 3 brings in some anatomy. A 65-year-old man with severe COPD on home oxygen needs a right distal humerus fracture fixed. Which regional block is preferred? The correct answer is D, infraclavicular blockade. Now here's why this really matters. Interscalene and supraclavicular blocks sit higher up, and they carry a much greater risk of knocking out the phrenic nerve, which paralyzes the diaphragm. For a patient with severe COPD who is already struggling to breathe, that could be disastrous. An infraclavicular block gives you the arm numbness you need, but it safely spares the phrenic nerve. Let's move to question 4. Which of the following muscle groups demonstrates the earliest recovery from neuromuscular blockade following a reversal agent? The correct answer is B, the diaphragm. And honestly, thank goodness it is. The diaphragm and other respiratory muscles recover significantly earlier than peripheral muscles, like the adductor pollicis in your hand. This is a crucial safety mechanism, ensuring a patient can actually breathe on their own before they regain full limb mobility. However, you still have to ensure both respiratory and upper airway muscles are fully awake and recovered before you ever extubate a patient. Question 5 presents a true anesthesia nightmare. Minutes after induction with sevoflurane and succinylcholine, a 23-year-old male spikes a temperature to 39.2 Celsius, his heart rate shoots to 148, his blood pressure skyrockets, and his muscles become incredibly rigid. What is the most appropriate first step? The correct answer is C, cessation of volatile anesthetics. This is a textbook hypermetabolic crisis known as malignant hyperthermia. While you absolutely will need to administer IV dantrolene, hyperventilate with 100% oxygen, and physically cool the patient, none of that matters even a little bit if you are still pumping the poison into them. Stop the triggering agents immediately. That is always step 1.
Question 6. Which of the following is a risk factor for intraoperative awareness during general anesthesia? The correct answer is A, use of neuromuscular blockade. The why here is actually pretty fascinating. A neuromuscular blockade paralyzes the patient, right? Normally, if a patient is getting too light under anesthesia, they might move or twitch, which signals the anesthesiologist to deepen the sedation. But if they are perfectly paralyzed, that natural warning sign is totally masked. Therefore, paralysis inherently increases the risk that inadequate anesthesia goes completely unnoticed by the team.
And finally, question 7. In which situation would succinylcholine be preferred over a non-depolarizing agent? The correct answer is B, rapid sequence intubation. Succinylcholine has an incredibly rapid onset. We are talking 30 to 60 seconds flat, and a very short duration. This makes it the absolute gold standard for rapid sequence intubation, or RSI, where getting that airway secured immediately is quite literally life or death. Just remember to avoid it in patients with severe burns, major neuromuscular disease, existing hyperkalemia, or a history of malignant hyperthermia.
So, the crucial point to take away today: succinylcholine's rapid onset and short duration make it the classic RSI drug.
Chapter 7, Critical Care. Starting with question 1. So, a patient develops significant hemoptysis and shortness of breath just minutes after insertion of a pulmonary artery catheter into a branch of the left pulmonary artery. Right after measuring the wedge pressure, what's the management? Option A, emergent tracheostomy. B, thrombolytics. C, pressure-controlled ventilation with reverse IDE ratio. D, left lateral decubitus position and urgent thoracic surgery consult. Or E, right lateral decubitus position and an urgent thoracic consult. Well, the correct answer here is D. Think about what just happened. This patient likely has a pulmonary artery rupture from inflating that balloon. The absolutely crucial move here is to place the bleeding lung in the dependent position. Basically, put the bleeding side down so blood doesn't flood into the good lung. Since the catheter is on the left, we use the left lateral decubitus position. So your exam pearl for this one: PA catheter plus sudden hemoptysis equals a pulmonary artery rupture. Put that injured lung down and get thoracic surgery on the line immediately. Moving right along to question 2, which is all about sedation during mechanical ventilation. Are we looking for A, deep sedation to minimize discomfort, B, communicate the method and goal level to the bedside nurse, C, a BIS less than 90 is sufficient for neuromuscular blockade, D, propofol leads to hypertension, or E, avoid ketamine and depressed cardiac function? The answer is B, As a rule, sedation should be minimal, and you absolutely must clearly communicate that specific target to the bedside nurse so they can titrate it properly. Let's quickly knock out those distractors. If a patient is actually paralyzed, your BIS monitor target needs to be 40 to 60, definitely not 90. Propofol? That causes hypotension, not hypertension. And actually scratch that whole avoid ketamine idea. Ketamine is really useful when cardiac function is depressed. Bottom line, target light sedation whenever you can, and if they're completely paralyzed, aim for a BIS of 40 to 60. Okay, question 3. This one gives us a pretty tense clinical scenario. A 72-year-old guy with a recent tracheostomy had a small amount of blood from his trach yesterday, but it stopped. Today, he developed significant hemoptysis and his respiratory status is just totally crashing. Next step, A. Intubate from above, remove the trach, and apply digital pressure to the innominate artery. B. Rush for a PE protocol CT. C. Call ENT. D. Throw in a chest tube. Or E. Initiate a massive transfusion protocol. The answer is A. The underlying pathology here is what makes this so terrifying. That tiny bleed yesterday, that was a herald or sentinel bleed. This is a classic textbook presentation of a tracheo-innominate fistula, a catastrophic connection between the trachea and the artery. You have to immediately control the airway, take out the trach, put your finger straight through the site to compress the artery right against the sternum, and prep for emergency surgery. Key insight here, tracheostomy plus a sentinel bleed, you've got to think tracheo-innominate fistula.
Let's hit question 4. We're looking at airway pressure release ventilation, or APRV. Does it A, increase peak airway pressure? B, provide additional time to eliminate CO2? C, require paralysis? D, increase mean airway pressure without increasing the peak? Or E, utilize an I to E ratio of 1 to 2? The correct answer is D. So APRV uses an inverse I to E ratio. What that actually means is it keeps the patient at a high pressure for a really long time and then just briefly drops it. This massively increases the mean airway pressure, which is great because it recruits those collapsed alveoli, but it does it without having to crank up the peak airway pressure, which we know can damage the lungs. And the best part? Patients can breathe spontaneously on it, so you don't even need paralysis. The vital concept to grasp for APRV. Prolonged high-pressure time increases mean airway pressure for much better alveoli recruitment.
Question 5. You have a patient with a trach that was placed just 2 days ago. He accidentally catches his collar and pulls the entire tube out. His respiratory status is actively declining. What's the next step? A. Bag mask over the site. B. Replace the tube and bag mask. C. Intubation from above with appropriate sedation. D. Bronchoscopy. Or E. Just block the site. The answer is C. The absolutely crucial point to remember here is that a fresh tracheostomy, meaning it's only a couple days old, has a very poorly developed tract. If you try to blindly shove that tube back into the hole, you are almost certainly going to push it into the pretracheal space. You'll create a false tract, and you could literally kill the patient. You have to secure that airway safely with endotracheal intubation from above. Remember this, fresh tracheostomy plus accidental decannulation, do not blindly replace the tube. Intubate from above.
Question 6. We've got an unknown patient rolling into the ED. They're hypotensive with jugular venous distension and cool skin. A PA catheter shows decreased cardiac output, increased wedge pressure, and increased systemic vascular resistance. What type of shock is this? A. Hypovolemic, B. Neurogenic, C. Late septic, D. Early septic, or E. Cardiogenic? The answer is E. Cardiogenic shock. Let's break down these hemodynamics. It's like a puzzle. The heart is acting as a failing pump, right? So cardiac output goes down. Because it's failing, fluid backs up, which means wedge pressure and JVD go up. Now, the body tries to compensate for all this by clamping down its blood vessels, so systemic vascular resistance spikes, which is exactly why the patient has cold, clammy skin. Core takeaway, decreased cardiac output, increased systemic vascular resistance, increased wedge pressure, and a cold patient, that equals cardiogenic shock for sure.
Okay, moving on to question 7, looking at steroid administration for septic shock. Is it A, based on a concentropin stimulation test? B, based on a random total cortisol less than 10? C, proven to decrease the duration of sepsis in all studies? D, high-dose dexamethasone? Or E, given for shock refractory to volume and vasoactive medications without needing a cortisol test? The correct answer is E. Current guidelines are super clear on this. If a patient is in septic shock and you've aggressively pumped them with fluids and maxed out vasopressors and they are still hypotensive, you add corticosteroids, specifically IV hydrocortisone. You literally do not have the time to sit around waiting for a cortisol test to come back. Action has to be immediate. The pearl here? Refractory septic shock, despite fluids and pressors, hit them with IV hydrocortisone immediately.
Question 8. You have a ventilated ARDS patient who suddenly develops severe respiratory distress, desaturation, tachycardia, and hypotension. He has severely diminished breath sounds on the right side, and his CVP has suddenly shot up. Next step: A. Bronchoscopy, B. Immediate needle decompression followed by tube thoracostomy, C. Volume resuscitation, D. Chest CT, or E. Decompressive laparotomy. The answer is B. Listen, sudden hypoxia, hypotension, and unilateral obscene breath sounds in a patient on a ventilator is a tension pneumothorax until proven otherwise. This is absolutely a clinical diagnosis. Do not even think about sending this crashing patient down the hall to the CT scanner. You have to perform an immediate needle decompression and then follow it up with a chest tube. Golden rule time. Tension pneumothorax is a clinical diagnosis, and unstable patient means immediate needle decompression. Question 9 focuses on stress ulcer prophylaxis. Should it be administered A. Only in patients with risk factors admitted to the ICU, B. All patients admitted to the ICU, C. Anyone who has an NG tube, D. Does it bypass increasing the risk of C. diff, or E. Is it simply not necessary in patients receiving corticosteroids? The correct answer is A. Now, I know it's incredibly tempting to just give every single ICU patient acid suppression, but you really shouldn't. Routine use without specific risk factors, things like prolonged mechanical ventilation or coagulopathy, is totally unnecessary. And worse, it actively increases the risk of complications, especially C. diff infections. Key takeaway: stress ulcer prophylaxis should be selective, not an automatic reflex for every single ICU admission. Wrapping up the critical care section with question 10. Which of these ICU patients actually needs a blood transfusion? Option A, a 26-year-old male with a femur fracture and a hemoglobin of 7.4. Option B, a 76-year-old with ESRD, pneumonia, and a hemoglobin of 8.2. Option C, an 84-year-old male post-op and STEMI with a hemoglobin of 7.9. Option D, a 56-year-old post-colon surgery with a hemoglobin of 8.6. Or option E, a 94-year-old bypass patient with a hemoglobin of 8.2. Take a quick second to absorb those numbers. The correct answer is C. The standard evidence-based strategy nowadays is restrictive, meaning we usually only transfuse stable ICU patients when their hemoglobin drops below 7. But look at option C. That 84-year-old just had an NSTEMI. That's a serious cardiac ischemic event. These patients often require a higher threshold to make sure we're getting adequate oxygen delivery to that struggling heart muscle. So your clinical bottom line: stable ICU patient, transfuse under 7. But if there's recent cardiac ischemia, you really need to consider a higher threshold. Great work so far. Chapter 8, burns. Let's keep that momentum going and dive straight into the second half. All right, question 1 for the burns section. A 31-year-old male is pulled from a house fire. He has burns to his face, chest, and arms. He's answering questions, but his voice is super hoarse. He is tachycardic, hypotensive, and breathing fast. But his oxygen saturation is sitting pretty at 98% on 2 liters. What's the next step? A, chest x-ray, B, aggressive fluid resuscitation, C, intubation, D, blood transfusion, or E, escherotomies? The answer is C. You've got facial burns plus hoarseness in a fire victim. That equals a severe inhalation injury. His airway is actively swelling as we speak. If you wait around for that 98% saturation to drop, well, by then it's going to be too late. The airway will be totally closed off and you won't even be able to intubate him. Early intubation is absolutely life-saving here. Crucial insight: facial burns plus hoarseness after a fire means early intubation. Do not let that normal oxygen saturation give you a false sense of security. Question 2. A patient spills hot tea on themselves, resulting in a scald burn that is red, blistered, and really painful to the touch. What's the depth of this burn? A, first degree, B, second degree, meaning partial thickness, C, third degree, or D, fourth degree. The correct answer is B. The physical exam basically tells you the whole story here. First-degree burns, like a mild sunburn, are red, but they don't blister. Full-thickness or third-degree burns are so deep they actually destroy the nerve endings, making them generally insensate or completely painless. Because this burn has blisters, it's moist, and it hurts a lot, it falls squarely into the second-degree or partial-thickness category. Rule of thumb: blisters plus pain, that's a second-degree burn. Let's do some rapid math for question 3. A patient comes in with second-degree burns to the anterior surface of both legs and the anterior torso. What is his total body surface area burn? Is it A, 18%, B, 36%, C, 45%, D, 54%, or E, 63%? The answer is B, 36%. So the trick here is just properly applying the adult rule of 9s. We know each entire leg is 18%, which means just the front or anterior surface of one leg is exactly half of that, 9%.
This patient burned both anterior legs, so that's 9 plus 9, giving us 18%. Now, the entire anterior torso is also worth 18%. Add those together, 18 plus 18, and you get a 36% total body surface area burn. Takeaway: master that adult rule of nines. Anterior leg is 9%, anterior torso is 18%.
Question 4 asks, what is the most common organism to cause burn wound sepsis? Is it A. E. coli, B. Group A strep, C. Staph epidermidis, D. Enterococcus, or E. Pseudomonas aeruginosa? The correct answer is E. The burn eschar is basically an all-you-can-eat buffet for bacterial colonization. And while tons of bugs can infect burns, there's one notorious culprit that absolutely thrives in this specific environment, and that is Pseudomonas aeruginosa. It's a major cause of burn wound infection leading to severe sepsis. You should also definitely keep fungi in the back of your mind for severely burned patients. But your fast fact for the boards: when you hear burn wound sepsis, think Pseudomonas first. Question 5. What is a notable side effect of the topical burn antimicrobial mafenate acetate? Is it A. Metabolic acidosis, B. Neutropenia, C. Hyponatremia, D. Thrombocytopenia, or E. Gastrointestinal upset? The answer is A. Now, mafenate acetate is fantastic for penetrating deep burn eschars, especially over cartilage like the ears. But the systemic absorption of it leads to the inhibition of an enzyme called carbonic anhydrase. This inhibition causes the kidneys to waste bicarbonate, which ultimately leads to a non-anion gap metabolic acidosis. The key mechanism you need to commit to memory: mafenate acetate causes carbonic anhydrase inhibition, and that results in metabolic acidosis. We're at question 6. A 42-year-old sustains a high-voltage electrical burn. He's got contact burns on his hands and feet, but amazingly, his EKG is totally normal. What is this patient highly at risk for? A. Respiratory distress, B. Renal failure, C. Hyperthermia, D. Hypothermia, or E. Infection?
The answer is B. High-voltage electrical injuries are tricky because they cause massive hidden damage to the muscles along the path the current took through the body. This leads to severe rhabdomyolysis. As all that muscle breaks down, it releases a massive amount of myoglobin into the blood. This huge protein gets filtered by the kidneys, but it precipitates in the tubules and clogs them up, causing acute renal failure. The high-yield sequence to remember: electrical burn means rhabdomyolysis, which leads to myoglobinuria and ultimately acute renal failure.
And finally, question 7. Which of these is critical for the management of significant burns? Option A, prophylactic antibiotics. Option B, early irrigation and debridement. Option C, adequate nutrition. Option D, A, B, and C. Or option E, just B and C. The answer is E. Look, significant burns trigger a massive, profound hypermetabolic response in the body. Because of that, aggressive nutrition and early surgical wound debridement are absolute mainstays of treatment. But notice what we left out of the correct answer: routine prophylactic systemic antibiotics. Giving a patient antibiotics simply because they have a burn is not recommended. It just breeds multi-drug-resistant superbugs. You treat actual confirmed infections. You don't prophylax them. The final bottom line: major burns require early wound care and aggressive nutritional support. No routine prophylactic antibiotics.
Chapter 9, Wound Care, focusing on healing, ulcers, and NPWT. Question 1. The statement, when does a well-healed wound reach the original strength of uninjured tissue? The answer? Never. Literally never. And the reason for this is that even after complete healing and tissue remodeling, a wound just doesn't regain 100% of its original tensile strength. So your absolute exam pearl here: a healed wound does not equal normal strength. Wounds never regain their original strength, and keeping that physiological limitation in mind is absolutely essential for your post-op management.
Moving right along to question 2. Statement: we have a 58-year-old diabetic male with a foot ulcer,
rest pain, and no infection. What's the best initial step? The answer is to order non-invasive vascular studies. Now, what's really interesting here is the reason. Rest pain? That is a huge red flag for significant arterial insufficiency. And you know inadequate perfusion severely impairs healing, right? So you must evaluate that vascular supply before you even think about picking up a scalpel for debridement. The exam pearl to lock in: diabetic ulcer plus rest pain plus zero infection means you assess circulation first.
Okay, question 3. Statement: an 85-year-old bed-bound female has a sacral ulcer completely covered in black eschar. What's the stage? The answer? The stage is unknown. The reason for this is pretty straightforward, but you'd be surprised how often it trips people up. That eschar acts like a visual barrier. You literally cannot determine the depth of tissue destruction until that eschar is removed. So, the exam pearl: any pressure ulcer completely covered by eschar or slough is unstageable. Plain and simple, you can't stage what you can't see.
Question 4 builds perfectly on this. Statement: after debridement, the wound bed is clean and non-infected. What's the next step? The answer: normal saline wet to moist dressing changes. Now why? The reason is vital for protecting your patient. Normal saline provides a nice, gentle mechanical removal of any residual devitalized tissue. If you use harsh chemicals like Dakin solution or hydrogen peroxide, you're actually going to damage healthy tissue and totally derail the healing process. So your exam pearl: clean, non-infected wound, stick to normal saline. Avoid peroxide or Dakins like the plague.
On to question 5. Statement: a patient has a gunshot wound to the abdomen, gets a colostomy, the fascia is closed, but the skin is deliberately left open. How will this wound heal? The correct answer is secondary intention. The clinical reason here is that because the skin is left open, the wound relies entirely on granulation tissue formation, contraction, and epithelialization to close that gap. Primary intention is when you directly close the edges together, but leaving it open is secondary. The exam pearl is super quick. Wound left open equals secondary intention.
Question 6. Statement: what are the benefits of negative pressure wound therapy, or NPWT? The answer is all of the above. It keeps the wound clean, decreases edema, increases angiogenesis, and increases granulation. The reason is that a wound vac is brilliantly multifaceted. It actively protects against outside contamination while kickstarting capillary growth and tissue formation. Your exam pearl formula to memorize: NPWT equals decreased edema plus increased angiogenesis plus increased granulation.
Let's finish up the wound care ward with question 7. Statement: which patient is an appropriate candidate for NPWT? Answer: a 63-year-old female with a non-infected diabetic foot ulcer after adequate debridement. The reason gives us our absolute contraindications. NPWT requires clean wounds. You absolutely cannot use it on untreated infections, exposed blood vessels, or if there is malignancy right there within the wound. So your exam pearl: know this cold. NPWT contraindications are infected wounds, exposed major vessels, and malignancy.
All right, shifting gears to Chapter 10, Head and Spinal Trauma. We're looking at brain injury and cervical spines. Question 1 of Chapter 10. Statement: a 27-year-old male motorcycle crash victim has a GCS of 14 and significant redness behind both ears. Next step? Answer: non-contrast CT of the head. Here's the reason. That redness behind the ears? That is battle sign. It's a classic physical exam finding that strongly points to a basilar skull fracture, which 100% mandates checking for an intracranial injury. Exam pearl: battle sign equals a basilar skull fracture, meaning you immediately order a non-contrast CT of the head. Question 2, and feel the urgency on this one. Statement: a 60-year-old female MVC victim is unresponsive and develops a new blown right pupil. Next step? Answer: elevate the head of the bed, hyperventilate, and order a bolus of mannitol. The reason? A newly blown pupil is a massive, screaming red flag. It means sharply increased intracranial pressure and impending brain herniation. You don't wait for a scan, you don't wait for a consult, you intervene right then and there. Exam pearl: trauma plus a new blown pupil means you treat elevated ICP immediately. Question 3. Statement: a 35-year-old male presents with basilar skull, facial, and C2 burst fractures. Prior to ICU transfer, what procedure is indicated? Answer: CTA of the neck. The reason comes down to the Denver screening criteria.
This patient has sustained catastrophic head and neck trauma, putting him at severe risk for blunt cerebrovascular injury. We're talking specifically about the carotid or vertebral arteries here. Example: high-risk facial and cervical fractures should automatically make you think of BCVI, which means getting a CTA of the neck.
Question 4. Statement: a 66-year-old intoxicated male post-MVC vehemently denies C-spine tenderness. Next step? Answer: place a cervical collar on the patient. The reason here is a rock-solid clinical and medical legal standard. An intoxicated patient is completely unreliable. Period. Their intoxication completely negates any ability to self-report, so you cannot clinically clear them. Definitive imaging is required. Example: for any unreliable or intoxicated trauma patient, you must maintain C-spine precautions.
Let's wrap up Chapter 10 with Question 5. Statement: a 54-year-old male with a GSW to the neck has an inaudible voice, an expanding hematoma, and is profoundly hypotensive. Action? Answer: secure the airway and attempts tamponade. The reason? This is an impending airway obstruction combined with hemorrhagic shock. You need immediate ABCs. Life-saving interventions always trump diagnostic imaging in an unstable patient. Do not delay for a CTA. Example: penetrating neck trauma, plus an airway threat, plus instability dictates you secure the airway and establish hemorrhage control first.
Moving right along into our final ward, Chapter 11, Chest Trauma. We're diving into tension and tamponade.
Question 1 of Chapter 11. Statement: a 34-year-old male with a GSW to the right chest is hypotensive, his trachea is deviated left, and breath sounds are absent on the right. Next step? Answer: needle decompression of the right chest. The reason should be obvious. You're looking at the absolute classic triad of a tension pneumothorax. This is strictly a clinical diagnosis, and it requires immediate decompression before you even think about a chest tube. Example: tension PTX is a clinical diagnosis. Do not wait for a chest x-ray. Decompress immediately. Question 2 brings us to a huge non-negotiable number, 1,500 milliliters. Statement: after inserting a chest tube, what finding prompts an immediate trip to the operating room? Answer: 1,500 milliliters initial output of blood, or 200 milliliters per hour over the next 2 to 3 hours. The reason is that a massive hemothorax hitting these exact thresholds signals significant ongoing intrathoracic hemorrhage. Only surgery can fix that. Example: hit 1,500 milliliters immediately or 200 milliliters an hour, and you are going straight to the OR.
Question 3. Statement: a 25-year-old female with a stab wound left of the sternum becomes pulseless. What is a key component of the resuscitative thoracotomy? Answer: incision in the pericardium anterior to the phrenic nerves. The reason is all about precise anatomical landmarks. You're doing a left anterior lateral thoracotomy at the fifth intercostal space, and you have to open the pericardium specifically anterior to the phrenic nerve to protect it. The only thing worse than a cardiac injury is accidentally paralyzing the patient's diaphragm while you're trying to fix it. Example: resuscitative thoracotomy. Always open the pericardium anterior to the phrenic nerve.
Let's move to question 4 and build that diagnostic toolkit. Statement: a 50-year-old woman strikes her chest on a steering wheel. How do you evaluate for blunt cardiac injury, or BCI? Answer: electrocardiogram. The reason is simple but definitive. An ECG is always the fastest, most appropriate first step. It checks for myocardial injury or arrhythmias to let you know if more monitoring is needed. Example: blunt chest trauma with suspected BCI means your very first test is an ECG. Question 5. Statement: a patient has neck and upper chest crepitus. What's the best test for an aerodigestive injury? Answer: esophagram with water-soluble contrast. The reason, that physical finding of crepitus, which is subcutaneous emphysema, is a massive warning sign for a tracheobronchial or esophageal tear. You have got to rule it out using direct contrast imaging. Example: trauma plus subcutaneous emphysema equals an immediate need for an esophagram or bronchoscopy.
Finishing the chest trauma ward with question 6. Statement: tension pneumothorax and cardiac tamponade are examples of what? Answer: obstructive shock. The reason ties the pathophysiology together perfectly. Both of these conditions mechanically obstruct cardiovascular filling and cardiac output, right alongside massive pulmonary embolisms. Example: the obstructive shock umbrella includes tension PTX, cardiac tamponade, and massive PE.
And finally, our final exam revisions. Time to master the pearls.
Here we go. These are your ultimate rapid-fire pearls. In the wound ward, rest pain plus a diabetic ulcer means you assess circulation first. A clean wound gets normal saline only. Head trauma ward. Battle sign triggers a non-contrast head CT. A new blown pupil means you treat elevated ICP immediately, absolutely no delays. And for the chest trauma ward, tracheal deviation with shock means you needle decompress instantly. And if your chest tube output hits 1,500 milliliters off the bat, you're going stat to the OR.
Okay, our first patient rolling into the bay. MCQ 1. We've got a 22-year-old male with a gunshot wound to the right buttock. He is hemodynamically totally normal. The CT scan points to an extraperitoneal rectal injury. You do a quick proctoscopy, you see some blood, but you can't quite pinpoint the exact level. At laparotomy, there is absolutely no interperitoneal injury. So what is the best next step? The answer is diversion with an end colostomy alone. Historically, a lot of us were taught the classic 3Ds: diversion, distal rectal washout, and presacral drainage. But evidence actually shows that routine washouts and drains can increase complications. So the absolute must-know exam pearl here, for an extraperitoneal rectal injury, the answer is diversion alone. Moving right along to Bay 2, MCQ 2. We have a 14-year-old girl who took a bicycle handlebar straight to the abdomen. She's complaining of nausea, vomiting, and back pain, but her vitals are completely stable. The scan shows a 3-centimeter duodenal hematoma that's basically acting like a roadblock, nearly occluding the lumen. What's our next best step? Well, the standard of care here is nasogastric drainage and TPN. You see, most traumatic duodenal hematomas will actually resolve spontaneously on their own, so we really want to manage them non-operatively if we can. But because this specific hematoma is causing an obstruction and totally preventing oral intake, we have to use NG decompression and start TPN while we wait for it to shrink. Example: duodenal hematoma equals conservative management with NG and TPN. Next up, MCQ 3. A 19-year-old male gets brought in after being ejected in a rollover motor vehicle crash. EMS had to intubate him in the field. His blood pressure is a scary 80 over palp. His chest and pelvic x-rays, perfectly normal. Now, the really interesting clinical distinction this case forces us to make is choosing the right imaging. What's the next step to find the source of his hypotension? The answer is a fast exam. You might be wondering, why not a CT scan? Simply put, this patient is in hemorrhagic shock and is profoundly unstable. There is absolutely no way we are sending a guy with a pressure of 80 over palp down the hall to the CT scanner. The fast is rapid, it's done right at the bedside, and it will find that interperitoneal bleeding. Exam pearl: an unstable trauma patient gets a fast, not a CT.
All right, MCQ 4. I want you to compare this patient's stability to our last guy. We have a 40-year-old morbidly obese male who took a gunshot to the flank. He is hemodynamically perfectly normal, and his abdominal exam is completely benign. No guarding, no rigidity. What is the next best step? Here, the answer is a CT abdomen/pelvis. Because he's so stable and doesn't have peritonitis, we actually have the luxury of time. We can safely send him to the scanner to define exactly what that bullet's trajectory was and see if it hit the peritoneal cavity or any retroperitoneal structures. The exam pearl to lock in: a stable flank GSW plus a benign abdomen means you go with the CT scan.
On to MCQ 5. A 64-year-old female arrives after being a restrained passenger in a high-speed MVC. She's got some right upper quadrant pain, but absolutely no peritonitis. Her vitals are rock solid. Blood pressure is 140 over 70. But then you see the CT scan and she's got a massive grade 4 liver injury. No contrast extravasation or blush though. What is the next best step? The answer is to admit her to the ICU, place a Foley, run Q6-hour CBCs, and do serial abdominal exams. It can feel so wrong to not operate when you see a terrifying grade 4 label on a scan, right? But the crucial takeaway is that hemodynamically stable blunt liver injuries are treated non-operatively. The grade 4 part just means she absolutely needs the ICU for extremely close monitoring. Exam pearl: stable blunt liver injury means non-operative ICU monitoring. But what if things go sideways? Let's look at MCQ 6. Imagine that exact same 64-year-old female, but she suddenly crashes. Her BP tanks to 90 over 50. We rush her to the OR, find a bleeding right hemiliver, and we pack it. But then anesthesia calls over the drape. Her pH is 7.1, her temp is 34 degrees Celsius, and her INR is 2.5. What's your next best step? We have to immediately stop and perform a damage control laparotomy, planning to return to the OR in 24 to 48 hours. Why? Because she's hit the absolute physiologic wall. She has the classic lethal triad: hypothermia, acidosis, coagulopathy. If you try to continue definitive surgery right now, you will literally kill her. We stop the bleeding, pack her up, correct your physiology in the ICU, and live to fight another day. Exam Pearl. The lethal triad demands damage control.
Base 7, MCQ 7. We've got a 22-year-old female brought in hypotensive and in severe hemorrhagic shock after a motorcycle crash. The nurse looks at you and asks what fluids we want to push right now. Think about it for a second. The answer? Typo-negative uncross-matched blood. She's actively bleeding out, so she needs blood, not just crystalloid. And crucially, because she's a female of childbearing potential, she specifically needs O-negative to prevent Rh sensitization. If we mess that up, it could seriously complicate any future pregnancies she might have. Exam Pearl, unstable bleeding female of childbearing age always gets O-negative blood. Rolling right into MCQ 8. A 36-year-old guy had to have his shattered spleen removed after a nasty ATV crash. It's now post-update 3, he's doing great, and he's heading home. But wait, which vaccines must he get prior to discharge? The answer is Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. Removing the spleen leaves patients highly susceptible to encapsulated organisms. This brilliantly illustrates a classic absolute must-know mnemonic for the boards: SHIN, S for strep pneumo, HI for Haemophilus influenzae, N for Neisseria. Exam Pearl, Aspiline means you better remember your SHIN vaccines. Shifting gears to MQ9. We have a 70-year-old female who fell down the stairs at her nursing home. Heart rate is 110, blood pressure soft at 90/50. Her pelvic x-ray reveals a really nasty open-book pelvic fracture. What is our immediate next step here? We need to call for the placement of a pelvic binder immediately. An open-book pelvis is essentially a rapidly expanding bucket just filling with blood. You've got to close the book. The binder provides rapid mechanical stabilization and, most importantly, reduces the pelvic volume to instantly tamponade that bleeding. The golden exam pearl, unstable open-book pelvic fracture means a pelvic binder goes on first. And here we are, the final case of our abdominal shift, MCQ 10. We're in the OR with a very stable patient who took a GSW to the anterior abdomen. We open up and find a small sigmoid colon defect, definitely less than 50% of the circumference, with very minimal spillage or contamination. What's our next step? The answer is just a primary repair alone. Now, in the past, surgeons might have instantly opted for a stoma here, but modern surgical logic dictates that if the injury is small, the contamination is minimal, and the patient is doing great hemodynamically, a primary repair is perfectly safe. Example, small colon injury under 50% in a stable patient gets a primary repair. Okay, take a deep breath. That was 10 heavy abdominal cases down. Now let's totally reset our focus as we start our second shift, Chapter 13. We are moving entirely into orthopedics and extremity trauma for the final 10 questions. Starting strong with MCQ 1 of our ortho shift, we are performing a medial approach dual incision fasciotomy for lower leg compartment syndrome. What structure must we release to actually get in there and access the deep posterior compartment? The answer? The soleus. Let's visualize the anatomy here for a second to build our intuition. To adequately decompress that deep posterior compartment proximally, you literally have to take down a portion of the soleus origin. There's just no way around it. Exam Pearl. Accessing the deep posterior leg compartment requires releasing the soleus origin. MCQ 2. We suspect compartment syndrome in a completely obtunded patient. They can't tell us if it hurts, so we have to rely on pressure measurements. We're looking for a difference of less than 30 millimeters of mercury between the compartment pressure and what? The answer is their diastolic blood pressure. This is critical physiology math right here. The delta pressure is simply calculated as diastolic BP minus the compartment pressure. If that gap narrows to less than 30, we have acute compartment syndrome on our hands. Exam Pearl. Delta pressure is DBP minus compartment pressure. Moving to MCQ 3, we're looking at different tibial plateau fracture patterns and assessing the potential for an associated vascular injury. Which specific pattern carries the absolutely highest risk? The answer? A medial plateau fracture dislocation. The mechanics of this are pretty fascinating. When the tibia displaces relative to the femur during a knee dislocation, it violently stretches the popliteal artery. Because that artery is tightly anchored both above and below the joint, it takes the brunt of that force and often tears. Example, any knee fracture dislocation must make us highly suspicious of a popliteal artery injury. MCQ 4. A 22-year-old male arrives after a bad MVC. He's hypotensive and tachycardic. The x-ray shows an anteroposterior compression pelvic ring injury. So, what's our next step? The answer is the application of a pelvic sheet or binder. Does this sound familiar? It definitely should. Just like our elderly patient back in abdominal MCQ 9, this AP compression injury basically tears open the pelvis.
the binder mechanically stabilizes things and crushes that internal volume down to stop the hemorrhage. Exam Pearl. AP compression injury in shock equals early pelvic binder.
Let's look at MCQ 5. A 27-year-old male polytrauma patient comes in with a left femur shaft fracture, but he's also got pulmonary failure and a persistently high lactate of 4.7. What is the treatment for his femur fracture right now on post-injury day 1? The answer is an external fixation. Listen, this patient is deeply under-resuscitated. If we decide to be heroes, take him to the OR and remount his femur for an intramedullary nail, we are going to deliver a massive physiological second hit that will almost certainly throw him right into ARDS. Instead, we use damage control orthopedics. Slap on a quick X-fix and get him to the ICU. Exam Pearl. Under-resuscitated polytrauma demands damage control orthopedics like an X-fix. On to MCQ 6, which highlights a very, very common pitfall in trauma wards. A patient gets extubated after 3 days in the ICU, wakes up, and finally tells us his foot hurts. Sure enough, we discover missed metatarsal fractures. The exam question asks us to fill in the blanks. Missed injuries are associated with what, located where, and decreased by what? The answers: intubation, distal extremities, and tertiary survey. It makes sense, right? Because an intubated patient can't give you any feedback. Injuries in the hands and feet are so easily overlooked during the initial chaos of the trauma bay. A formal tertiary survey catches them. Exam Pearl. Missed injuries happen in distal extremities, and the tertiary survey prevents them. MCQ 7. We're talking about tibia pylon fractures and how they differ from your run-of-the-mill ankle fractures. They are the result of what force and what energy? The answer: axial force and high energy. These aren't simple, I twisted my ankle playing basketball injuries. These happen when a tremendous axial load drives the talus straight up like a hammer into the distal tibia, absolutely shattering it. We're talking high-speed MVCs or huge falls off ladders. Exam Pearl. A pylon fracture equals axial load plus high energy. Connecting directly to that massive high-energy force we just talked about, let's look at MCQ 8. Because of that force, pylon fractures are often treated in stages, using an initial spanning external fixation. This staging decreases the risk of what major complication? The answer: surgical site infection. Because pylon fractures involve such massive, violent force, the surrounding soft tissues are incredibly traumatized and swollen. If we slice right through that swollen, mangled tissue on day 1 to put our plates in, the infection rates absolutely skyrocket. So we X-fix it first, let the swelling drop over a couple of weeks, and then go back in to fix the bone definitively. Exam Pearl. Pylon soft tissue swelling dictates staged fixation to decrease infection. Down to the wire with MCQ 9. Let's revisit this second hit concept one more time to really cement it in your brain. If we perform intramedullary nail fixation of a femur fracture in an under-resuscitated multi-trauma patient, it is associated with which severe complication? As we touched on back in MCQ 5, the answer is acute respiratory distress syndrome, or ARDS. Reaming out the canal of a long bone releases fat and massive amounts of inflammatory mediators into the bloodstream. In a patient who is barely clinging to stability in the first place, that IM nail acts as the fatal second hit. Exam Pearl. An under-resuscitated patient plus an IM nail equals a high risk of ARDS. And here we are, the final patient of our shift. MCQ 10. A 23-year-old female presents with an open humerus shaft fracture after a crash. On exam, you notice she is completely unable to extend her wrist, fingers, or thumb. What should definitive treatment include? The answer: debridement, irrigation, exploration of the radial nerve, and internal fixation. That classic wrist drop means the radial nerve has been injured as it spirals around the back of the humerus. Now, because the fracture is open, we're going to the OR anyway to wash it out, so we absolutely must explore that nerve while we're in there cleaning the wound and fixing the bone. Exam Pearl. Humeral shaft fracture with a wrist drop pretty much guarantees a radial nerve injury.
All right, starting right off with Chapter 14, Surgical Procedures, Central Venous Access, and Site Selection.
Jumping straight into Chapter 14, MCQ 1. The statement: a 38-year-old morbidly obese male with chronic kidney disease needs total parenteral nutrition. Where is our best access site? The answer: the right internal jugular vein. And the reasoning here is absolutely crucial. This patient has CKD, meaning he might need hemodialysis via an AV fistula down the line. You have to preserve those subclavian veins, because a catheter there can cause stenosis, literally ruining that future dialysis access. Well, what about the femoral vein? Nope. His morbid obesity makes the growing a massive infection risk, so the right internal jugular hits the sweet spot.
Okay, keeping the momentum for MCQ 2. The statement: a 25-year-old trauma patient, GCS of 2, unmeasurable blood pressure, requiring active CPR.
Where does the central line go? The answer is the right femoral vein. The reasoning here comes down to pure logistics during a crisis. If you're doing chest compressions and managing an airway up at the head, you need a site that is completely out of the way. The femoral vein lets you get rapid access without disrupting the life-saving work happening on the upper half of the body.
Flowing right into MCQ3, a direct follow-up. Statement, let's say that trauma patient survives, goes to the ICU. What do we do with that central line we just placed during the code? The answer, you must replace it within 48 hours. Why? Because emergency lines are essentially dirty lines. You cannot guarantee a perfectly sterile field while someone is actively coding. If you leave it in past 48 hours, the risk of a catheter-related bloodstream infection skyrockets.
Moving on to MCQ4. Statement. You're doing a diagnostic paracentesis on a patient with ascites and an ileus. Where do you poke? Answer. The left lower quadrant. The reasoning is all about dodging anatomical landmines. Think of it like a map. A midline approach on a patient with an ileus is risky because those bowel loops are super distended. You might puncture them. Upper quadrants, you risk hitting the liver or spleen. The left lower quadrant is your safe zone, keeping you clear of the big organs and the transverse colon.
Down to MCQ5. Statement. You need to place a femoral central line during CPR, but there's no palpable pulse. How do you find the vein? Answer. 1 to 2 centimeters medial to the midpoint between the anterior superior iliac spine and the pubic tubercle. When you can't feel a pulse, you are flying on pure anatomy. Just remember the mnemonic NAV. From lateral to medial, it's nerve, artery, vein. The artery sits at that anatomical midpoint, so you know the vein is literally just a centimeter or two right next to it medially.
For MCQ 6, statement, you accidentally place an 8 French catheter into the carotid artery. Next step. Answer. Consult vascular surgery for removal in the OR. Listen, the clinical reasoning here is a massive exam pearl. Do not, under any circumstances, just pull that catheter out. Pulling a large bore catheter from an artery can cause a catastrophic expanding hematoma or stroke. Leave it exactly where it is so the vascular team can remove it safely under controlled conditions.
Wrapping up this first chapter with MCQ 7. Statement. What is an absolute contraindication for a right subclavian central line? Answer. A patient presenting with fever and edema of the right arm. Why? Because that right arm swelling is a giant red flag for a suspected deep vein thrombosis. You absolutely cannot place a catheter into a venous system that has an active blood clot. You have to pivot and find another site.
Okay, let's keep this momentum going into Chapter 15, Acute Abdomen, Diagnosing and Managing Surgical Emergencies.
Starting Chapter 15 with MCQ1. Statement. A 16-year-old has vague periumbilical pain that shifts into sharp, localized right lower quadrant pain. What causes that shift? Answer. Irritation of the parietal peritoneum. The reasoning explains the classic appendicitis presentation. Early on, the inflammation only aggravates the visceral peritoneum, which just gives you that dull, vague, my stomach hurts somewhere in the middle feeling. But as it swells and touches the abdominal wall, the parietal peritoneum, bam, the pain becomes sharp and perfectly localized.
MCQ 2. Statement. An 84-year-old man becomes suddenly unresponsive 2 hours after complaining of abdominal pain. Priority step? Answer. Obtain IV access, basic labs, and a rapid plain X-ray. The core reasoning here is triage. This guy might have a ruptured AAA or perforated viscus. He is unstable. Do not send an unresuscitated, unstable patient to the CT scanner. And don't immediately induce anesthesia for intubation, which could tank his pressure completely. You do your ABCs and resuscitate first.
Over to MCQ 3. Statement. A 30-year-old woman, 24 weeks pregnant, RLQ pain, elevated white count. Next diagnostic step. Answer. Ultrasound of the abdomen and pelvis. The reasoning is pretty straightforward but highly testable. You want to completely avoid exposing the fetus to ionizing radiation from a CT scan. Ultrasound is always your first move. Actually, if the ultrasound is totally inconclusive, your backup plan is an MRI. Again, to dodge that radiation.
Right on the heels of that is MCQ 4. Statement. The ultrasound confirms acute appendicitis in our pregnant patient. Treatment? Answer. Urgent laparoscopic appendectomy. The reasoning here is that pregnancy is absolutely not a reason to wait and watch appendicitis. It's the exact opposite. If that appendix perforates, you're looking at peritonitis and maternal sepsis, which is incredibly dangerous for both the mother and the fetus. Get in there and take it out. Moving strictly along to MCQ 5. Statement. 74-year-old institutionalized female, chronic constipation, massively dilated sigmoid colon. Next step? Answer: immediate sigmoidoscopic reduction. The reasoning is that this is the textbook presentation of a sigmoid volvulus. Basically, the colon is twisted on itself. As long as her vitals are stable and she doesn't have dead ischemic bowel, you grab a scope and untwist it from the inside as your very first move.
And that leads us to MCQ 6. Statement: you've successfully untwisted the volvulus. Now what? Answer: bowel preparation followed by surgical resection. The reasoning is that while the scope fixed the acute problem, that extra-long floppy colon is still sitting there. If you send her back to the nursing home, it's just going to twist again. So during the same admission, you do a bowel prep and a definitive sigmoid colectomy to remove the root cause.
For MCQ 7, statement: a 35-year-old man is febrile, hypotensive, vomiting, and lying completely still in the fetal position. Most urgent test? Answer: plain chest and abdominal x-rays. The clinical picture here, a rigid, guarded abdomen in a toxic patient, screams perforated viscus. You need to look for free air under the diaphragm. A plain upright chest x-ray is incredibly fast. If you see free air, boom, immediate surgery. You bypass the slow CT scan entirely.
Finally, MCQ 8. Statement: a 65-year-old hypotensive male with a known AAA, sudden abdominal pain, and altered mental status. Next step. Answer: urgent aneurysm repair. The reasoning here is a classic exam rule. Known AAA plus sudden pain plus low blood pressure equals a ruptured aneurysm. It's a ticking time bomb. Don't waste time confirming it with a CT scan, and don't flood him with IV fluids which can just wash out his clotting factors. Go straight to urgent surgical or endovascular repair.
All right, Section 3, high-yield exam traps. Let's consolidate everything we've just covered.
Let's lock these 15 consecutive scenarios in. From preserving subclavian veins and chronic kidney disease, to leaving accidental arterial catheters exactly where they are. We saw why you always untwist a sigmoid volvulus with a scope before you take them to the OR, and why a known AAA with acute pain skips the CT scanner entirely.
All right, let's look at MCQ 1. We've got a 57-year-old female presenting with an air fluid level in the posterior mediastinum on her chest x-ray. A barium swallow shows a large herniation. So what's her most likely diagnosis? The correct answer here is D, a combination or type 3 hiatal hernia. Why? Well, because a type 3 uniquely combines two features. Both the gastroesophageal junction and a portion of the stomach have herniated up into the thorax. Just to recap, a type 1 is just the sliding GE junction. A type 2 is just the fundus popping up while the junction stays anchored down in the abdomen. But when you get both of them sliding up into the chest, that's definitively a type 3. And that is exactly what creates that massive air fluid level you're seeing in the mediastinum.
Moving right along to MCQ 2. Here we have a 62-year-old female with a newly diagnosed type 3 hiatal hernia, and a whopping 40% of her stomach is up in her chest. She's got severe dysphagia and breathlessness, so what is the most appropriate treatment option? The answer is C, hiatal hernia repair with a callus gastroplasty. Look, here is the mechanical reality of this situation. A massive, chronic type 3 hernia physically shortens the esophagus because that GE junction has just been sitting way up in the chest for so long. If a surgeon just grabs that shortened esophagus, pulls it down into the abdomen, and staples it, you're creating massive tension, and it's absolutely going to fail. Instead, you need a lengthening procedure. A callus gastroplasty actually solves this by creating a tube out of upper gastric tissue, basically extending the esophagus so it sits nicely below the diaphragm, tension-free. You wouldn't just give a PPI here. This is a mechanical, anatomical failure, not just acid reflux. So lock this pearl in your mind right now. Short esophagus equals callus.
Section 2, GERD and surgical options. We're looking at MCQs 3 through 6 here.
Let's tackle MCQ 3. A 45-year-old male with worsening epigastric pain undergoes an esophageal manometry study. Which finding indicates an abnormal lower esophageal sphincter, or LES? The right answer is A, an intra-abdominal length of 0.5 centimeters. According to the strict criteria, an abnormal LES is defined by a resting pressure under 6 millimeters of mercury, a total length of less than 2 centimeters, or an intra-abdominal length of less than 1 centimeter. So falling down to that 0.5 threshold perfectly defines a defective sphincter. And why does this matter to us? Because having even one of these abnormal parameters means the patient has a 90% probability of suffering from severe reflux.
For MCQ 4, picture a 40-year-old woman with sharp epigastric pain 3 days a week. She smokes a pack a day, and her BMI is 32. What's her initial therapy?
The definitive answer is A, a 3-month trial of lifestyle modifications, specifically weight loss, smoking cessation, and elevating the head of her bed. This is your classic textbook first-line management from mild to moderate GERD. Now, why do we completely avoid option B on the test? Because that distractor suggests drinking peppermint tea and resting in bed after meals. But peppermint actually relaxes the esophageal sphincter, and lying down takes away gravity, so both of those things will actively make her acid reflux worse. And obviously, jumping straight to surgery or aggressive endoscopy is just way too invasive for an initial, uncomplicated presentation.
So, the crucial takeaway in MCQ 5 is how we tailor our surgical approach. The question asks, which procedure reduces postoperative dysphagia in a GERD patient who also has abnormal esophageal motility? The correct answer is E, the two-pet fundoplication. Think about it mechanically. A standard Nissen is a complete 360-degree wrapper on the esophagus. If your patient already has weak esophageal motility, putting a 360-degree wrap around it creates way too much resistance. They literally won't be able to swallow their food, leaving them with severe dysphagia. The two-pet, on the other hand, is a 270-degree posterior partial wrap. It gives you the reflux control you need, but it leaves enough give so that a weakened esophagus can still push food through. So remember, abnormal motility plus GERD equals two-pet.
Building right on that, MCQ 6 gives us a young woman who physically cannot belch after undergoing a Nissen fundoplication, leading to severe retained air in her stomach. Which anti-reflux procedure reduces this specific complication, which we call gas bloat syndrome? The answer is C, the Belsey Mark IV repair. Gas bloat syndrome happens when that complete 360-degree wrap is just too tight, trapping all that swallowed air. The Belsey Mark IV is a partial 240-degree wrap, and because it doesn't encircle the esophagus entirely, it beautifully preserves the patient's normal anatomical ability to vent air by belching, which practically eliminates gas bloat syndrome altogether.
Moving on to Section 3, Motility Disorders and Achalasia, covering MCQs 7 through 10.
MCQ 7 asks a very straightforward question. What is the most common symptom of achalasia? The answer is E, dysphagia. But the absolute brilliant clinical distinction you need to make here is the type of dysphagia. Achalasia causes progressive dysphagia to both solids and liquids right from the very onset. This is a massive diagnostic clue for you. If a patient has a mechanical obstruction, like say a tumor or a stricture, they're going to struggle with solids first and only start choking on liquids much later as the lumen narrows. But because achalasia is a neuromuscular failure, specifically the sphincter failing to relax combined with absent peristalsis, fluids just pool right up alongside the solid food.
In MCQ 8, we're managing a 70-year-old achalasia patient with COPD and diabetes, and their symptoms just aren't improving on calcium channel blockers. Best next step? The answer is A, peroral endoscopic myotomy, or POEM. When medical therapy fails, we absolutely have to definitively disrupt that tight lower esophageal sphincter. Adding nitrates, that's just a temporary band-aid for a structural problem, so we don't do that. And we definitely wouldn't do a two-pay fundoplication because that's for reflux, not achalasia. Since our patient is elderly with significant comorbidities, the POEM procedure is incredible here. It gives us a definitive surgical myotomy of the muscle entirely from the inside using an endoscope, which really minimizes the physiological stress on the patient.
Looking at MCQ 9, we've got a 65-year-old female coming in with atypical chest pain. She's actually been ruled out for a myocardial infarction 3 times already, but her manometry shows prolonged high-amplitude peristaltic waves. The diagnosis, answer C, is nutcracker esophagus. This scenario brilliantly illustrates how esophageal spasms can perfectly mimic cardiac ischemia. The major key to differentiating this on the test is the manometry. Achalasia lacks normal peristalsis entirely, right? Diffuse esophageal spasm shows uncoordinated premature waves, but nutcracker esophagus is characterized by these excessively powerful high-amplitude waves that literally squeeze the esophagus with tremendous force, and that's what causes that severe heart attack-like chest pain. For MCQ 10, a 50-year-old male is essentially dragged into the clinic by his wife because of a chronic cough and absolutely foul-smelling breath, and he admits he's been regurgitating undigested food. This is the textbook classic presentation for D-Zenker diverticulum. A Zenker is essentially a little pouch that forms at the back of the throat at a weak spot known as Killian's dehiscence. It's driven by dysfunction of the upper esophageal sphincter. So food just gets trapped in this pouch, sits there, and literally rots, which causes that severe halitosis and the regurgitation of undigested food. Keep in mind, anatomically speaking, this is a false diverticulum because it only involves the mucosa and submucosa pushing out through the muscle wall, not all the layers of the esophagus.
Section 4. Perforations, Barrett's, and tumors. MCQs 11 through 15. Let's get into the heavy hitters.
MCQ 11 asks for the most common cause of esophageal perforation. The definitive, no hesitation answer is D, iatrogenic injury. Roughly 75% of all esophageal perforations are caused by us, by medical instrumentation during endoscopies or stricture dilations, and it usually happens at anatomical narrowings, like the cricopharyngeus. Now, listen closely. The boards absolutely love to trick you here. They want you to take the bait and pick Boerhaave syndrome, which is that spontaneous rupture caused by forceful vomiting. But while Boerhaave is famous, and frankly fatal if missed, iatrogenic injury is far and away the most common cause of perforation overall. Don't fall for the trap.
For MCQ 12, a 60-year-old male with chronic GERD is found to have Barrett's esophagus with low-grade dysplasia on a biopsy. What's our next step? Answer A is correct. Continue medical therapy and do an endoscopic surveillance in 6 months. The rule here is strict. For low-grade dysplasia, we suppress the acid and we watch it very closely. We strictly reserve aggressive treatments like mucosal resection, radiofrequency ablation, or a massive surgery like an esophagectomy for high-grade dysplasia or an established cancer. Jumping to surgery way too early for low-grade changes exposes your patient to totally unnecessary, life-altering risks.
Answering MCQ 13 regarding the overall 5-year survival for esophageal adenocarcinoma, the grim reality is B, just 20%. Why is it so low? Well, the esophagus is highly distensible, and it completely lacks a serosal layer. That means tumors can grow quite large and actively invade adjacent mediastinal structures long before they ever cause enough dysphagia for the patient to notice and seek help. So by the time we actually diagnose it, it is frequently already reached an advanced stage, locking that overall survival rate at a pretty devastating 20%. And this perfectly sets up our next point in MCQ 14. Which of the following is a risk factor for esophageal adenocarcinoma? The correct answer is A, intestinal metaplasia, which is literally the histological definition of Barrett's esophagus. Adenocarcinoma is a disease of the lower esophagus, and it's driven by GERD, obesity, and Barrett's. The distractors they give you in the question, things like achalasia or specific geographic locations, along with smoking and heavy alcohol use, those are actually major risk factors for squamous cell carcinoma, which typically hits the upper and middle esophagus. You've got to keep these two distinct pathological pathways separated in your mind for the exam.
Wrapping up our formal questions with MCQ 15, we're asked which condition can be treated by enucleation from the esophageal muscular wall. The answer is B. Esophageal leiomyomas. Leiomyomas are benign, intramural tumors, meaning they grow inside the actual muscle layer of the wall itself. Because of where they sit, a surgeon can elegantly slice the muscle open, pop the tumor out whole, which is what we call enucleation, and then sew the muscle back up without ever breaching the inner mucosal lining of the esophagus. You simply can't do this with intraluminal polyps because those are on the inside lining, and you definitely can't do it with invasive cancers, which require wide radical resections.
Section 5, High-Yield Exam Pearls. The 8 cold associations. Let's bring it all home. I want you to burn these 8 associations into your memory right now. Ready? Type 3 hernia means both the junction and the stomach are up in the chest. A short esophagus absolutely requires a Cullis lengthening gastroplasty. If you have motility issues combined with GERD, you do a toupee partial wrap. Want to prevent gas bloat syndrome? Use the 240-degree Belsey wrap. Achalasia presents with dysphagia to solids and liquids simultaneously. High-amplitude waves on a manometry scream nutcracker esophagus. An elderly patient with halitosis and undigested food, that's a Zenker diverticulum. And finally, the most common cause of esophageal perforation is iatrogenic instrumentation. Know these cold. These are guaranteed points on your exam.
As we wrap up this explainer, I want to leave you with one final, critical thought regarding our most common complication. We know iatrogenic injury causes most perforations, right? But an esophageal leak into the mediastinum is rapidly, brutally fatal if it is not managed.
What's really interesting about this section is how it tests your ability to spot those critical exceptions in bariatric surgical indications. Just memorizing the basic rules, yeah, that won't save you here. You really have to understand the nuances.
Kicking things off with MCQ 1, we have a 50-year-old woman with poorly controlled diabetes and a BMI of 33. Now, her weight has fluctuated despite a physician-supervised diet and exercise program over the past year, and she's unsuccessfully tried multiple programs over 7 years. So what's the move? The correct answer is B, recommend bariatric surgery after multidisciplinary evaluation. Now, you might be thinking, wait, doesn't she need a BMI over 35? Usually, yes. But here is the critical exception. A BMI between 30 and 34.9 combined with poorly controlled type 2 diabetes or metabolic syndrome is an indication for surgery.
So continuing failed conservative treatments, that's option A, is just insufficient. Option C says her BMI isn't severely obese enough, and option D is a classic trap trying to get you to delay until her BMI hits 35. Both are incorrect. Option E is out because B is absolutely appropriate. Don't let them trick you with that BMI over 35 rule.
Shifting gears from chronic management to an acute post-operative crisis in MCQ2. The key here is recognizing the signs of strangulation. We've got a 29-year-old woman, just 4 days post-Roux-en-Y gastric bypass. She's got severe abdominal pain, persistent nausea and vomiting, tachycardia, and a borderline blood pressure of 100/65. Plus, her CT reveals distended small bowel loops. The only correct answer is A, intravenous fluid resuscitation and prompt surgical exploration. Look, the combination of a recent bypass, obstruction, severe pain, and systemic instability, that literally screams internal hernia and bowel ischemia. Option B, doing serial exams, is totally inappropriate for an unstable patient. Option C, just tweaking her pain meds, completely ignores the life-threatening pathology. And option D, getting a gastrographin study, that dangerously wastes precious time when the clinical picture already demands surgery. Resuscitate and operate.
Moving on to MCQ3, which deals with a totally different bariatric complication. Here we have a 37-year-old woman, 10 weeks out from a laparoscopic adjustable gastric banding. Her band was tightened 2 weeks ago, and now she's got severe heartburn, nausea, and persistent vomiting. So what is the most appropriate next step? It's E, immediate removal of all fluid from the adjustable band. Guys, this is a purely mechanical problem. The band is simply too tight and it's obstructing the gastroesophageal junction. Let's rule out those distractors. Option A, a CT scan, is absolutely not the first step for a known, easily reversible mechanical issue. Option B, placing an NG tube, that's not going to fix a tight band. And options C and D, giving acid blockers or advising her to eat smaller meals, are completely useless for a physical obstruction. Just deflate the band first.
Let's see how this all builds on patient safety with MCQ4. We've got a 52-year-old woman, 3 months post-sleeve gastrectomy, presenting with a 5-centimeter, painless, easily reducible periumbilical hernia. She is losing weight adequately, so what do? We go with D. Defer surgical management until her weight loss is stabilized and nutritional status is optimized. You see, after bariatric surgery, rapid weight loss and nutritional shifts severely impair wound healing. Because her hernia is painless and reducible, meaning no incarceration or strangulation, immediate repair, which is option A, is totally unnecessary. Option C, urgent admission to optimize nutrition, is massive overkill for someone who's completely asymptomatic, and option B is wrong because we don't need to unnecessarily restrict her exercise. That activity is supporting her ongoing weight loss. You just wait 12 to 18 months for her weight to stabilize.
Wrapping up Chapter 18 with MCQ5. We have a 45-year-old woman, 1 year post-Roux-en-Y, complaining of epigastric pain. Endoscopy shows a 1.5-centimeter ulcer right near the gastrojejunostomy. The question asks, what factors are associated with this condition, classically known as a marginal ulcer? The answer is E, all of the above. I really want to meticulously explain this because every single factor listed plays a part. NSAIDs, they block protective prostaglandins. H. pylori causes direct mucosal inflammation. Smoking, it severely impairs tissue healing, and poor tissue perfusion, or ischemia at the anastomosis, creates a weak point in the mucosa. You absolutely must recognize that all of these, options A, B, C, and D, are direct culprits for developing a marginal ulcer.
All right, let's dive right into Chapter 19, Small Intestine, where the focus shifts dramatically to bowel obstructions, fistulas, and highly specific tumor markers.
Starting Chapter 19 with MCQ1, a 29-year-old male presents with 2 days of abdominal pain and bilious vomiting. His past surgical history includes an open appendectomy, and his CT shows dilated small bowel loops with a transition point. The correct etiology here is C, adhesions. In an adult with previous abdominal surgery presenting with a small bowel obstruction, well, it's adhesions until proven otherwise. Let's eliminate the others. Option A, intussusception, is really rare in adults and usually has a distinct lead point. Option B, malignancy, is super unlikely given his age and history. Option D, Crohn's disease, lacks any supporting clinical features in this prompt. And option E, gallstone ileus, typically occurs in much older patients with air in the biliary tree. Now, MCQ2 brilliantly illustrates the difference between simple and complicated obstructions. We have a 45-year-old male with an SBO and previous abdominal surgeries. But look at these vitals. Fever of 39 degrees Celsius, tachycardic to 115, hypotensive at 90/54. He's got rebound tenderness, guarding, and free fluid on his CT. What do we do? The only acceptable answer is B, urgent laparotomy. This patient clearly has peritonitis and sepsis, which strongly suggests an ischemic or strangulated bowel. Option A, admission for close monitoring, would be lethal in a patient with dead bowel. Option C, getting an upper GI contrast study, wastes critical time. Option D, reassurance, is obviously absurd. And option E, colonoscopy, is evaluating the completely wrong organ for a small bowel issue. You have to resuscitate and cut.
For MCQ3, the prompt describes a 70-year-old male with abdominal pain, bilious vomiting, and a painful left groin bulge that's been there for 4 hours. But crucially, his vitals are completely stable, and there are absolutely no overlying skin changes. Based on these clinical findings, this fits perfectly into the incarcerated hernia category. Therefore, the answer is A, attempt manual reduction in the ED with light sedation. Because there are no signs of strangulation or systemic toxicity, we do not rush to an urgent laparotomy, making option D incorrect. Getting a CT scan, option B, just delays bedside care. And option C, discharging him, that completely ignores his acute obstruction. We try gentle manual reduction first.
In MCQ4, a 56-year-old female is 2 weeks post-ileocolic resection and now has stool draining directly from her midline incision. Her abdomen is soft and non-tender, and her vitals are perfectly stable. The question asks what is not indicated. The answer is D, urgent laparotomy. What we have here is an enterocutaneous fistula. In a stable patient, we follow the SNAP protocol: sepsis control, nutrition, anatomy definition, and plan for definitive surgery later. That means options A, skin protection, B, quantifying the output, and C, bowel rest and nutrition are all heavily indicated. Option E, a CT scan, is also indicated to help define the anatomy. But rushing into a hostile, recently operated abdomen for an urgent laparotomy? That is the one thing you absolutely do not do. Moving to MCQ5, and what's truly fascinating here is the direct marker to treatment association. We've got a 60-year-old female with an SBO, a jejunal mass, and liver metastases. The biopsy reveals cells that are c-KIT positive. The answer is A, imitinid mesylate, also known as Gleevec. When you see c-KIT, which is also known as CD117, you immediately diagnose a gastrointestinal stromal tumor, or GIST. And for a metastatic GIST, imitinib is the gold standard targeted therapy. Let's strictly rule out the others. Option B, 5-FU and oxaliplatin. That's for colon adenocarcinoma. Option C, CHOP therapy, is used for lymphoma. Option D, trastuzumab, targets HER2-positive breast or gastric cancers. And option E, octreotide, manages symptoms for neuroendocrine tumors, not GISTs.
Speaking of neuroendocrine tumors, let's tackle MCQ 6. A 45-year-old male has a widely metastatic small bowel neuroendocrine tumor and presents with flushing and diarrhea. The correct answer for controlling these symptoms is C, octreotide. This patient is suffering from carcinoid syndrome. The tumor is releasing vasoactive substances, like serotonin, straight into the systemic circulation. Octreotide is a somatostatin analog that binds to receptors and directly suppresses the release of those substances. Options A and B are chemotherapies that just won't provide rapid symptom control for this syndrome. And options D and E are generic antidiarrheals that completely fail to address the underlying hormonal cause of his systemic flushing.
Finishing up Chapter 19 with MCQ 7. We have a 10-year-old girl on long-term TPN via a central line. She presents with a fever of 39.5, tachycardia, and hypotension. Crucially, her physical exam is completely unremarkable, and her abdominal X-rays are normal. The most likely acute diagnosis is B, central venous catheter-associated bloodstream infection. When a patient has a central line and shows systemic instability with zero localizing signs, well, that line is guilty until proven innocent. We can confidently eliminate option C, intra-abdominal abscess, and option E, small bowel perforation, because her abdominal exam and imaging are totally normal. Option D, pneumonia, is unlikely without any respiratory symptoms. And option A, hyperthyroidism, just doesn't fit this acute infectious picture at all.
All right, Chapter 20, Surgical Diseases of the Liver. Let's navigate the complex surgical decision-making required for patients with cirrhosis and hepatic masses.
Diving straight into Chapter 20 with MCQ 1, we have a 50-year-old female with alcoholic cirrhosis presenting with an incarcerated umbilical hernia showing overlying skin changes. Her platelets are at 90,000 and she's heading to the OR. How do we minimize complications? The answer is C, placement of an intraperitoneal drain after hernia repair. The crucial point here is that you cannot delay an emergency for medical optimization, which makes option A incorrect. Option B is wrong because her platelets are 90,000. The threshold for most invasive procedures is 50,000, so she doesn't need a transfusion. Option D, pre-op paracentesis, just wastes time. And option E, simply giving antibiotics, is a death sentence for ischemic bowel. We place a drain because postoperative ascites leakage through the surgical wound will cause profound wound breakdown and sepsis.
Next up, MCQ 2. We've got a 60-year-old male with hepatitis C who experiences moderate hematemesis postoperatively. He's normotensive with a hemoglobin of 9.8. After placing large-bore IVs and starting fluid resuscitation, the next best step is D, endoscopy with banding of varices. Listen, in a patient with liver disease, you must always assume hematemesis is variceal in origin. Endoscopy is beautifully dual purpose here. It's both diagnostic and therapeutic. Option A, transfusing to a hemoglobin over 10, is wrong because a restrictive transfusion strategy is actually preferred to avoid increasing those portal pressures. Option C, initiating propranolol, is a huge trap. Beta blockers are for secondary prophylaxis, not for controlling an active acute bleed. And option E, a TIPS procedure, is a salvage therapy, not a first-line treatment.
MCQ 3 brings us to a 54-year-old woman with a solitary 4-centimeter hepatocellular carcinoma, or HCC. Her liver function is totally normal, and she has no portal hypertension. The correct management here is E, perform a non-anatomic resection of the mass with 2-centimeter margins. Because her liver function is preserved, she's a prime candidate for resection. A non-anatomic wedge resection is favored over option C, a formal right hepatectomy, because it preserves way more functioning liver tissue. Option A, a biopsy, is totally unnecessary and potentially risks seeding when the imaging is already characteristic in a high-risk patient. Option B, rushing her to a transplant list, ignores the fact that she has easily resectable disease right now. And option D, ablation, has higher recurrence rates for tumors of this size compared to a clean surgical resection.
Now, MCQ 4 brilliantly illustrates how treatment algorithms can shift over time. 3 years later, this exact same patient returns with 2 new 2-centimeter hepatic lesions near the resection bed. The question asks what is contraindicated. The answer is B, resection of each of the lesions. You see, once hepatocellular carcinoma becomes multifocal or metastatic, routine repeat surgical resection is generally taken right off the table. That makes options A, C, D, and E, which are TACE, ablation, transplantation, or systemic therapies like sorafenib, the actual viable pathways, depending on her exact clinical status. But multifocal disease means we step away from the scalpel.
For MCQ 5, we're asked which of the listed liver lesions mandates operative excision. The options include focal nodular hyperplasia, simple cysts, hemangiomas, bile duct hamartomas, and an asymptomatic 6-centimeter hepatic adenoma. The answer is undeniably A, the 6-centimeter hepatic adenoma. Even though this patient is completely asymptomatic, an adenoma larger than 5 centimeters simply must come out due to the dual, life-threatening risks of spontaneous hemorrhage and malignant transformation. Options B, C, D, and E represent FNH, cysts, hemangiomas, and hamartomas. All of these are overwhelmingly benign and can be safely observed if they aren't causing any symptoms. Adenomas are the dangerous exception.
Okay, Chapter 20 is done. Now, let's wrap this all up with our rapid-fire exam pearls.
Let's bring it all together by reviewing the absolute highest yield associations from these 17 rigorous questions. These are the patterns you need instantly available in your working memory. BMI between 30 and 34.9, combined with poorly controlled diabetes, bariatric surgery can be indicated. Adult presenting with an SBO and a history of previous abdominal surgery, it's adhesions. A GIST that is KIT positive, give them imatinib. A neuroendocrine tumor causing flushing and diarrhea, treat with octreotide. And a hepatic adenoma larger than 5 centimeters, resect it immediately due to the risks of bleeding and malignancy.
Let's start our gauntlet right in the right upper quadrant.
Question 1 hits us with a 70-year-old male who has mild acute cholecystitis and a distended gallbladder on a CT scan. The correct answer here is C, initiate antibiotics and IV fluids. The absolutely crucial takeaway for stable, mild acute cholecystitis is that you don't need some emergent midnight surgery, right? And since the CT already confirms the diagnosis, you can completely skip the HIDA scan or ultrasound. The standard of care is simply starting IV fluids and antibiotics first, which then sets you up for an early laparoscopic cholecystectomy once your operative resources are fully ready.
Moving right along to question 2, we have a 30-year-old female post-C-section presenting with elevated pancreatic enzymes, but crucially, there's no common bile duct dilation or stones seen on her ultrasound. The correct answer is D. Schedule a laparoscopic cholecystectomy during the same admission. So without any hard evidence of persistent CBD obstruction, jumping straight to an ERCP is totally the wrong move. To prevent recurrent and potentially fatal biliary events, she needs that lap chole before she leaves the hospital, right after her clinical symptoms improve.
Question 3 is an absolute life or death scenario. We have a 60-year-old male who is highly unstable with an ejection fraction of just 25%, severe jaundice, and dilated intrahepatic ducts. The correct answer is A. Percutaneous transhepatic cholangiography with decompression. This perfectly highlights a major triage priority. When you have a critically ill patient suffering from life-threatening ascending cholangitis, diagnostic delays like ordering an MRCP or waiting on tumor markers are totally out of the question. You need urgent percutaneous transhepatic decompression to save this guy's life.
Let's switch gears to a pathology scenario for question 4. A 50-year-old male has an incidental T1A adenocarcinoma confined entirely to the lamina propria. The correct answer is E. If there is a negative cystic duct margin, no further intervention is required. Honestly, this is a massive relief for the patient. Because the cancer is T1A, meaning it hasn't invaded beyond the mucosa or lamina propria, a simple cholecystectomy is definitive treatment. You definitely don't need any extended liver resections or annual MRCP surveillance.
For question 5, we are faced with every general surgeon's worst nightmare: intraoperative suspicion of a transected common bile duct during a lap chole. The absolute correct answer is B. Perform an intraoperative cholangiogram, or IOC. Never, ever blindly attempt to repair or just drop a drain and ignore a suspected bile duct injury while you're still in the OR. An intraoperative cholangiogram is absolutely mandatory to map the anatomy and pinpoint the exact level of injury before you make your next move.
Chapter 22, Surgical Diseases of the Pancreas. Questions 1 to 6.
Kicking off the pancreas section with question 1, we're given a 60-year-old male alcoholic with diabetes and specific lab values, and we're asked which finding actually increases his mortality risk. The correct answer is A, H. Looking at the classic admission Ranson criteria, which includes age over 55, white count over 16,000, glucose over 200, LDH over 350, and AST over 250, we can easily rule things out. While he has diabetes and a mild bilirubin elevation, those simply aren't Ranson criteria. His age of 60 is the only value presented that officially signals increased mortality.
Question 2 looks at a 45-year-old female recovering from mild pancreatitis, but she has an unclear etiology. The correct answer here is B, right upper quadrant ultrasound. You know, every single unexplained pancreatitis case needs a simple, non-invasive RUQ ultrasound to actively hunt for gallstones before you even think about discharging them. Jumping straight to an ERCP or an abdominal CT scan are totally incorrect first steps when you're just looking for the most common culprit.
Moving to question 3. What do you do for a 73-year-old male with an asymptomatic 2-centimeter side branch IPMN without any worrisome features? Well, the correct answer is C, observation. When you have an incidental finding like this that completely lacks high-risk features, stuff like obstructive jaundice, an enhancing mural nodule, or main duct dilation, aggressive surgeries like total or distal pancreatectomies are absolutely the wrong answer. Standard clinical surveillance is the way to go here.
Now, question 4 gives us a stark contrast. We have a 35-year-old female with a 3.5-centimeter cyst in the pancreatic tail that does not communicate with the main duct and has high mucin levels. The correct answer is A, distal pancreatectomy. Unlike the last question, this presentation is the classic setup for a mucinous cystic neoplasm. Because these specific lesions have a known malignant potential, simply observing it or draining it is incorrect. She definitively needs surgical resection.
Question 5 is a super high-stakes scenario. A patient is 2 weeks post-Whipple with a known pancreatic fistula and suddenly has new bloody drain output. The correct answer is C, angiogram. Guys, this is a terrifying but classic complication. A sentinel bleed 2 weeks after major pancreatic surgery is a visceral artery pseudoaneurysm until proven otherwise. Getting an angiogram for rapid diagnosis and immediate endovascular embolization is the true life-saving choice here, avoiding a highly dangerous exploratory laparotomy if at all possible.
Wrapping up the pancreas with question 6.
A 60-year-old fit female presents with painless jaundice and a clearly resectable 2-centimeter pancreatic head mass with a suspicious biopsy. The correct answer is B, pancreaticoduodenectomy. For a physically fit patient with a definitively resectable pancreatic head cancer, ordering repeat biopsies or trying upfront neoadjuvant therapies when it's already clearly resectable just delays the inevitable. The gold standard definitive treatment is to take her straight to a Whipple procedure.
Chapter 23, Surgical Diseases of the Spleen. Questions 1 to 10. Let's finish strong. Question 1 in our spleen section asks for the true statement regarding thrombotic thrombocytopenic purpura, or TTP. The correct answer is C. Plasmapheresis improves survival compared with plasma infusions. While TTP absolutely does involve a severe Adams TMS13 deficiency, the most therapeutically crucial fact tested here is that urgent plasmapheresis is your definitive first-line move. It physically removes those dangerous autoantibodies and replaces the enzyme, which actively improves long-term survival.
Question 2 tests the defining characteristics of splenic abscesses. The correct answer is D. They are most commonly due to seeding from a distant site of infection. Forget about gram-negative rods being the primary cause or relying on hyperechoic CT lesions. The absolute key here is that they almost always seed from a distant hematologic source, most classically infectious endocarditis caused by staph or strep species.
For question 3, we're looking at overwhelming post-splenectomy sepsis, or OPSS. The correct answer is D. It may be prevented with the use of prophylactic antibiotics in selected patients. The clinical reality here is that OPSS is primarily driven by Streptococcus pneumonia, not H. influenzae. And because of this specific lethal vulnerability to encapsulated organisms, selected high-risk patients, especially young children, can actually be shielded effectively with prophylactic antibiotics.
Question 4 is a pure rapid-fire board classic. What is the most common cause of elective splenectomy? The correct answer is D, idiopathic thrombocytopenic purpura, or ITP. While blunt trauma undoubtedly dominates the emergent non-elective cases, and hereditary spherocytosis is a common reason overall, you've got to know that ITP takes the crown as the single most common elective indication for the procedure.
Look at question 5. We have a 25-year-old female with an incidental 2-centimeter proximal splenic artery aneurysm. The correct answer is E, proximal and distal ligation of the splenic artery. The vital takeaway here is that a 2-centimeter aneurysm in a woman of childbearing age carries a massive, life-threatening rupture risk during pregnancy. Because this specific lesion is proximal, we aggressively treat it with simple ligation, which preserves the spleen via the collateral circulation.
Question 6 presents a classic trap. A 55-year-old female, 7 days post-splenectomy for myelofibrosis, develops abdominal pain and a fever. The correct answer is B, portal vein thrombus. Fevers and pain a full week out in a patient with a massive myeloproliferative spleen isn't a bowel perforation or C. diff, it's a splenic or portal vein thrombosis. You need to get an immediate contrast-enhanced CT and start systemic anticoagulation.
For question 7, we need to locate the most common site of an accessory spleen. The correct answer is E, the splenic hilum. This is a critical detail. If you're taking out a spleen for a hematologic disorder like ITP, you absolutely cannot miss an accessory spleen, or the disease will just recur right back. 80% of the time, you're going to find that extra tissue hiding right there in the splenic hilum.
Question 8 tests optimal vaccination timing. What's the optimal timing for a pneumococcal vaccination in an adult undergoing an elective splenectomy? The correct answer is A, 14 days before surgery. While emergency trauma cases get vaccinated 2 weeks post-op once they stabilize, an elective surgery demands you vaccinate at least 14 days beforehand. Why? Because the spleen actually needs to be present to mount an optimal immune response to the vaccine.
Question 9 compares our surgical approaches, asking what laparoscopic splenectomy has an increased risk for compared to the open approach. The correct answer is A, hemorrhage. When you compare them, laparoscopy drastically drops your pneumonia rates, wound infections, and length of stay. But it distinctly increases your relative risk of intraoperative bleeding and hemorrhage, largely due to the technical challenges that end up leading to open conversions.
And finally, question 10 asks what the vaccination bundle for a post-splenectomy patient should include. The correct answer is E, all of the above. This is the ultimate asplenia bundle. You need every single one of these vaccines to protect against encapsulated organisms, plus the flu shot to prevent secondary bacterial infections.
Starting off with question 1 on the Rome criteria for constipation. So what's the correct answer here? It's A, 3 or fewer bowel movements per week.
Now, the real trick to this question is the 25% rule. Things like manual maneuvers, which is option B, and the sensation of incomplete evacuation in option D, well, they only need to hit a 25% threshold. It's not 50 or 100%. And we can toss out option C right away because irritable bowel syndrome is a completely separate diagnosis, not a requirement here. So your big exam pearl to memorize? Just remember 25% plus less than 3 bowel movements per week.
Moving on to question 2, which focuses on neostigmine for Ogilvy syndrome. You might be wondering, why is a monitored setting so absolutely crucial for this? It all comes down to C, the high risk of severe bradyarrhythmias. Remember, neostigmine is an acetylcholinesterase inhibitor, meaning it produces some really potent cholinergic effects. Sure, it triggers a large evacuation, like in option A, and sometimes you'll see hypotension in option B, but severe bradycardia? That is the true life-threatening concern. Oh, and don't let option D fool you. Perforation is a risk of the bowel dilation itself, not the medication. The pearl here is simple. Monitor the heart, and always have atropine ready.
For question 3, we're looking at the most critical initial aspect of care for a lower GI bleed. And the answer is B, resuscitation and stabilization. Hemodynamics must always precede localization. Knowing this instantly pushes aside option A, which suggests obtaining an early scan. It also makes option C, a fecal occult blood test, totally irrelevant for someone with obvious active bleeding, right? And while placing an NG tube, option D, can help rule out an upper GI source, it's just not the fundamental first step. Simply put, resuscitate before you localize.
Next up, question 4 covers the definitive treatment for sigmoid volvulus, which is D, sigmoidectomy. The logic you need to apply here is absolutely crucial. Initial treatment is typically endoscopic decompression, which means options A and B are only temporary fixes that carry huge recurrence rates. And option C, sigmoidopexy, it just isn't the standard operation. Once the patient is optimized, you literally must remove that segment. So, lock in this key pearl. Scope first for the acute phase, but surgery later for the definitive cure.
Hitting question 5, we're asked about the most common cause of significant lower GI bleeding. That would be A, diverticulosis. This type of bleeding is characteristically sudden, completely painless, and arterial. Just knowing that clinical picture helps us cross off option C, ischemic colitis, because that usually presents with actual abdominal pain. Now, while colorectal cancer in option B and ulcerative colitis in option D can definitely bleed, they just aren't the most common culprits for significant acute hemorrhage. Your golden pearl for this one? Painless, brisk hematochezia equals a diverticular bleed.
For question 6, we need to know what characterizes Hinchey IV diverticulitis. The answer is B, fecal peritonitis. Let's break down the other stages to clarify exactly why. A periconic abscess, which you see in option A, is Hinchey 1. A pelvic abscess in option D, that's Hinchey 2. And generalized purulent peritonitis in option C is Hinchey 3. So the critical memory pearl you want to lock in for this classification is straightforward. Hinchey 3 is pus, but Hinchey IV is feces.
Moving right along to question 7, which asks us to distinguish Crohn's disease from ulcerative colitis. The correct answer is C, perianal disease. Crohn's is a transmural process that can affect literally anywhere from the mouth to the anus. That means we can quickly dismiss option A, because Crohn's absolutely does have skip lesions. Options B and D are out of the running too, since both of these diseases respond to biologic therapy and both can actually present with pyoderma gangrenosum. The contrasting pearl to keep in mind? Crohn's is transmural with fistulas and perianal disease, whereas UC is a continuous mucosal disease that always starts in the rectum.
Let's check out question 8 regarding surgery for medically refractory ulcerative colitis. The answer here is B, total proctocolectomy with an ileal anal anastomosis, or IPAA. Because UC puts the entire colonic and rectal mucosa at a really high risk for cancer, a definitive cure means you have to take out both. This makes option C, a segmental colectomy, pretty dangerous because it leaves at-risk mucosa behind. Now, while a total abdominal colectomy, option D, is used in acute settings, it's not the final restorative step. And an APR, option A, simply isn't the standard restorative choice here.
Tackling question 9. How exactly do you confirm suspected ischemic colitis after an endovascular aortic aneurysm repair, or EVAR? The answer is A, flexible sigmoidoscopy. EVAR can actually compromise the inferior mesenteric artery, and a flex sig lets you directly visualize that ischemic mucosa. A CT scan, option B, can suggest ischemia, sure, but it can't confirm it definitively. Plain films in option D are way too nonspecific, and a barium enema, option C, is just outright contraindicated if you suspect ischemia or perforation. So the Pearl, post-AAA repair plus hematochezia dictates a flex sig.
For question 10, what is the most common type of colonic polyp diagnosed? That's going to be D, hyperplastic polyps. These are highly common, benign lesions. Now, while adenomatous polyps in option A are the most important premalignant lesions we look for, they just aren't the most common overall. Malignant polyps in option B and hamartomatous polyps in option C make up a much, much smaller minority of findings. Let's reinforce the Pearl here. Hyperplastic is the most common, but adenoma is the most important.
Advancing to question 11 on the Kudo classification. The answer is C. It predicts the risk of lymph node metastasis and guides surgical resection. Because the Kudo pit pattern evaluates surface features to predict deep submucosal invasion, it isn't used for adjuvant chemotherapy decisions like option B suggests, nor is it for judging the technical ease of endoscopic retrieval in option D. It goes way beyond simply diagnosing malignancy, which sets aside option A, by linking the depth of invasion directly to surgical needs. On question 12 regarding family history and colonoscopy screening when a patient's father had colon cancer. The absolute most critical factor here is C, the age of the patient's father at diagnosis. An earlier onset in a first-degree relative dictates earlier screening protocols for the patient. Other factors like recent weight loss in option A, smoking history in option B, or maternal breast cancer in option D, they just don't dictate familial colorectal screening timelines in the same way. The crucial exam Pearl to remember, always ask, how old were they when diagnosed?
Moving to question 13. We're dealing with a T3 tumor and 0 out of 9 positive lymph nodes. The correct advice here is B. Adjuvant therapy should be considered due to an inadequate lymph node harvest. The benchmark is 12 nodes. Examining fewer than 12 risks understaging a tumor that might actually have occult nodal disease. This means we can't safely say no therapy is needed, eliminating option A. Furthermore, this is currently staged as stage 2 disease, not stage 3, which rules out options C and D entirely. Stamp the number 12 into your memory for adequate staging.
Question 14 covers appropriate imaging for rectal cancer staging. The answer is A, chest X-ray, abdomen CT, and pelvic MRI. You need to check the lungs, the liver, and the local pelvic tumor depth. Now, understanding this brilliantly illustrates why we can instantly dismiss B, C, and D. All three of those options include a routine PET CT, which is absolutely not required for standard initial staging. Rectal cancer staging equals chest, abdomen, and pelvic MRI.
Finishing up our first section with question 15, surgical resection principles for rectal cancer. The core requirement is B, ensuring an intact and complete total mesorectal excision, or TME. This is a non-negotiable oncologic fundamental for reducing local recurrence. As for the other options, you actually want to preserve the hypogastric nerves, contradicting option C to prevent urinary and sexual dysfunction. Routine resection of Denon-Villiers fascia, option A, isn't universally required, and we certainly don't do a routine APR based strictly on a 5-centimeter cutoff, setting aside option D.
Chapter 25, Anorectal Disease. Let's keep this rapid-fire sprint going.
Starting off Chapter 25 with question 1 on post-hemorrhoidectomy complications. The most likely issue here is D, urinary retention. This is triggered by intense pain and pelvic autonomic reflexes. While sphincter injury in option A and bleeding in option B are important, they're just less common. Infection, option C, is actually quite rare, and anal stenosis in option E is a delayed complication, not an immediate one. The clinical pearl to take away: limit perioperative IV fluids to keep urinary retention at bay.
Moving to question 2, managing a complex anal fistula that crosses both sphincters. The correct answer is B, division of the internal sphincter and placement of a ceton. Cutting the external sphincter blindly, like option A suggests, risks devastating fecal incontinence, which is obviously a no-go. Antibiotics alone in option D won't cure it. A diverting colostomy in option C is massive overkill, and an advancement flap, option E, is a later definitive step, not the initial one. The pearl? Preserve the sphincter with a ceton.
On question 3, regarding the goal of the distal transection margin in rectal cancer, the answer is A, 2 centimeters. The data consistently shows that extending the distal margin beyond 2 centimeters just doesn't lower local recurrence rates. This sufficiently knocks out options B, C, and D, which suggest unnecessarily large margins like 4 or 5 centimeters, as well as option E, which is dangerously short at under 5 millimeters.
Just remember this classic exam rule, 2 centimeters. For question 4 on the anal sphincter mechanism, the correct statement is B. The increase in pressure during voluntary contraction is due to the external sphincter, which is skeletal muscle. In contrast, the internal sphincter found in option A is autonomic. Furthermore, the internal sphincter accounts for a whopping 80% of resting pressure, which totally invalidates option C. And regarding options D and E, rectal distension actually causes the involuntary relaxation of the internal sphincter via the rectoanal inhibitory reflex, not the external.
Tackling question 5 on anal squamous cell carcinoma. The first-line treatment here is C, primary chemoradiation therapy. Using the NIGRO protocol is brilliant because it avoids a permanent colostomy and preserves the sphincter. This means an APR, option B, is absolutely not routine first-line therapy anymore. Low anterior resection, option A, is for rectal cancer, not anal. And local excision in options D and E just isn't the standard for typical SCC. Hammer home this absolute pearl. Chemoradiation, not a primary APR.
We are at our penultimate question, question 6. This is about a patient with biopsy-proven perianal Paget disease. The correct answer is E. Wide local excision is the most appropriate treatment in non-invasive disease. Because this condition is heavily associated with underlying colorectal cancer, patients absolutely do require a colonoscopy to hunt for visceral cancers. This proves option B false. An APR, option A, isn't automatically required. Fulguration in option D isn't standard definitive treatment, and it typically targets older adults, making option C incorrect too.
Concluding with question 7, on a young man with a severe posterior midline anal fissure, the correct statement is C. 90% of patients heal with conservative medical treatment like fiber, sitz baths, and nifedipine. This huge success rate makes option B, a fissurectomy, strictly secondary. Option A is false because lateral sphincterotomy is actually highly effective for refractory cases. We can ignore option D because most occur posteriorly, not equally. And option E is wrong because the classic triad involves a hypertrophied papilla, not an internal hemorrhoid. So I'll leave you with this.
Starting with Chapter 26. Let's look at question 1. Which one of the following is not considered a risk factor for stroke and TIA? The options are A, age greater than 55, B, African American or Hispanic race, C, female gender, D, hypertension, and E, smoking. The correct answer is C, female gender. While women do account for a higher proportion of stroke deaths, largely just because they live longer, female sex itself is not a major general risk factor in this context. We can confidently eliminate age, race, hypertension, and smoking because those are all massive risk factors. Your takeaway pearl here is that age plus hypertension, smoking, and atherosclerosis equal your big stroke risks. Moving seamlessly to question 2. A 67-year-old male has a right carotid brie. Duplex ultrasound shows 50% right carotid stenosis. According to the ACAS trial, carotid endarterectomy for asymptomatic patients is indicated for stenosis defined by which threshold? We have A through E ranging from 90% down to 50%. Well, the answer is D, greater than or equal to 60%. The patient in the stem only has 50%, so he simply doesn't meet the criteria. We can eliminate 90, 80, 70, and 50. The rule of thumb to remember, ACAS equals asymptomatic, greater than or equal to 60% with a perioperative stroke or death rate of less than 3%.
Now for question 3. According to the NOSIT trial, what is the approximate reduction in stroke rate over 2 years if a carotid endarterectomy is completed for a symptomatic patient with 70% stenosis? Options range from a 6% to a 20% absolute risk reduction. The correct answer is D, a 17% absolute risk reduction. Why? Well, NOSIT demonstrated an approximately 26% stroke risk with medical therapy versus just 9% after CEA. Subtract the two, and boom, you get a 17% absolute risk reduction. We can eliminate the distractors like 13%, which is actually historical ECST data, and 7%, which is for moderate 50 to 69% stenosis. So, the crucial point is, NOSIT symptomatic 70% or greater yields about a 17% absolute stroke risk reduction.
Moving on to Section 2. Let's shift to the surgical side of Chapter 26, focusing on procedural anatomy, endarterectomy complications, and stenting.
Question 4 asks, which of the following represents the major cranial nerve most commonly injured during carotid endarterectomy? Is it the vagus, hypoglossal, glossopharyngeal, facial, or recurrent laryngeal nerve? The answer is B, the hypoglossal nerve, or cranial nerve 12. Because of its highly variable course near the carotid bifurcation, it's particularly vulnerable, and injuring it causes ipsilateral tongue weakness. The other nerves can be injured, sure, but it's far less common. Moving right to question 5. Which vein is commonly ligated during carotid endarterectomy? Facial, internal jugular, superior thyroid, anterior jugular, or subclavian? The answer is A, the facial vein. It crosses immediately from the internal jugular and physically obstructs your exposure of the carotid sheath, so it gets tied off. We eliminate the internal jugular, which is meticulously preserved, and the others simply aren't routinely in the way. Question 6 brings us to some classic anatomy. The first intracranial branch of the internal carotid artery is which of the following? The answer is D, the ophthalmic artery. Remember, the internal carotid has absolutely no extracranial branches in the neck. After entering the cranium, the ophthalmic is the first major branch. So we eliminate the thyroid and lingual arteries, which belong elsewhere. Let's compare this directly to question 7. The first branch of the external carotid artery is what? The correct answer is A, the superior thyroid artery. The external carotid follows a classic inferior to superior sequence, starting exactly there. You can safely cross out the inferior thyroid, which actually comes from the thyrocervical trunk, and the ophthalmic. For question 8, we have a 72-year-old female with TIAs and an 80% left carotid stenosis. What's the next step? Since she is symptomatic with a severe stenosis over 70%, NASCET tells us the answer is E, recommend carotid endarterectomy. Observation or antiplatelets alone are totally inappropriate here, and standard CEA beats stenting unless she is specifically high risk. Now, what's really interesting is how this connects to question 9. Question 9 asks, the following by themselves are all acceptable indications for carotid artery stenting except, the answer is B, contralateral internal carotid artery occlusion. Stenting is generally reserved for patients who are high risk for open CEA, so things like a surgically inaccessible lesion, contralateral vocal cord paralysis, prior neck surgery, or prior neck radiation, those are all completely valid high-risk reasons to stent. But contralateral occlusion alone, that's not enough to automatically mandate a stent over open surgery.
Let's wrap up Chapter 26 with question 10. While undergoing carotid stenting, a patient develops bradycardia and hypotension during predilation. This is most likely due to what? The correct answer is C, stretching of the carotid body. Balloon predilation stretches that carotid bulb, stimulating baroreceptors and triggering a massive vagal response. We can easily eliminate global hypoperfusion or atheroembolism. Those cause neurological events, not sudden hemodynamic drops. The pearl here, carotid stent ballooning equals bulb stretch, which equals a vagal response.
Section 3 signals a major anatomical shift for us. We're moving from the neck straight down into the abdomen as we start Chapter 27, tackling abdominal aortic aneurysms, or AAAs. Let's methodically work through these AAA diagnosis parameters. Question 1 asks, which of the following is not associated with the development of an AAA? The surprising answer is A, diabetes mellitus. While smoking, hypertension, hyperlipidemia, and family history are massive classic risk factors, diabetes actually has an observed inverse association. Wild, right? Question 2, which diagnostic modality is least useful for AAA? CT, ultrasound, MRI, or aortography? The answer is D, aortography. Aortography only outlines the flowing lumen. It totally misses the true external diameter if there's any mural thrombus, heavily underestimating the actual aneurysm size. Question 3. Which patient can be medically managed? A 75-year-old male at 6.3 centimeters, a female growing from 4.9 to 5.3, a male at 4.8 with intractable pain, or a 70-year-old male growing from 4.8 to 5.1 centimeters? The correct answer is D, the asymptomatic 70-year-old male at 5.1 centimeters. The classic elective repair thresholds are 5.5 centimeters for men and 5.0 centimeters for women. We eliminate the others because they exceed thresholds, are rapidly expanding, or actively symptomatic. Moving right along into Section 4, let's explore post-operative complications and the technical nuances of endovascular aneurysm repair, or EVAR. Question 4 presents a patient 24 hours post-AAA repair with purple-black toes but palpable pedal pulses. The next step? Answer D, expectant management. This is your classic blue toe syndrome from microembolization. Because large arteries are patent, which we know because we feel the pulses, limb perfusion is intact. There is no need for emergent surgery or amputation. We manage it expectantly. Contrast this with the absolute dire scenario in question 5. 10 hours post-op, a patient is febrile, hypotensive, with diarrhea and diffuse tenderness. Sigmoidoscopy shows transmural necrosis. The next step? Answer C, emergent resection of the involved segment. Transmural necrosis means that bowel wall is dead. Any delay tactics like IV hydration alone, rectal tubes, or waiting will lead directly to perforation, sepsis, and death.
For question 6, during an EVAR, both hypogastric arteries are inadvertently covered. This can cause all of the following except. Answer C, small bowel ischemia. The hypogastrics supply the pelvis, meaning the buttocks, colon, perineum, and spinal collaterals. The small bowel is supplied higher up by the superior mesenteric artery. So we eliminate the pelvic structures as the exception. Question 7 demands immediate action. Post-ruptured EVAR, a massively transfused patient is anuric with a tense distended abdomen and peak airway pressures of 50. The next step? Answer A, emergent laparotomy and decompression. This is textbook abdominal compartment syndrome. The tense abdomen is literally crushing the kidneys and lungs. You absolutely cannot just observe or flush a Foley catheter here. You must open that abdomen.
Let's break down question 8 regarding the structural layers of the aorta. The true statement is C. The adventitia is composed of loose connective tissue and fibroblasts. We can eliminate the distractors because the intima is endothelium, not smooth muscle, and the media is the major site of aneurysmal degeneration, not the adventitia. Question 9 asks, all of the following are contraindications to EVAR except. The correct answer is C, an occluded left hypogastric artery. If it's already occluded, you aren't sacrificing anything new by placing a stent graft over it. We cross out the true contraindications, like a dangerously short 4 mm proximal neck or a horseshoe kidney.
Question 10. This brilliantly illustrates the ever-confusing topic of endoleaks. Which statement is true? Let's meticulously map out these concepts in our heads. Type 1 is a proximal or distal attachment leak. Type 2 is retrograde flow from collateral branches. Type 3 is a graft component separation or fabric failure. Type 4 is graft porosity, and Type 5 is endotension without a visible leak. Therefore, the only true statement given in the options is C. Type 3 endoleaks are due to inadequate seal or disconnection of the graft components.
Question 11 hits on outcomes. Large-scale studies comparing EVAR to open repair show a reduction in all of the following except. Answer D, 4 years survival rates. Look, EVAR is fantastic for short-term wins. It massively lowers perioperative morbidity, mortality, and hospital stay length. We eliminate A, B, and C. But long-term trials like EVAR-1 show that those survival lines eventually merge. There's simply no long-term survival advantage. Let's transition into Section 5, moving up into the thoracic cavity and the mesenteric vessels for the final stretch of complex clinical scenarios. Question 12 presents a 78-year-old male with a 5-centimeter descending thoracic aortic aneurysm. Which is true? Answer D. In the absence of symptoms, this can safely be watched until 6 centimeters. We eliminate immediate repair because 5 centimeters is below the classic 6-centimeter thoracic threshold. We eliminate median sternotomy because descending aneurysms use a thoracotomy. And we definitely eliminate the claim that there is no endovascular role because TEVAR is a vital everyday tool here.
Let's compare two highly critical questions. Question 13, a 68-year-old with sudden tearing chest pain and an intimal flap in the ascending aorta. Next step. Answer B, emergent open repair with conduit replacement. Any dissection involving the ascending aorta is a Stanford Type A, which is an absolute surgical emergency due to rupture and tamponade risks. Do not delay for a TEE, get to the OR. Contrast that with question 14, a 56-year-old with chest pain for 3 weeks and a flap distal to the left subclavian. The pain improves with blood pressure control, which is true. Answer A, evaluate for endovascular coverage. Because it's distal to the subclavian, it's a Type B. Because it's been 3 weeks, it's chronic. While medical therapy with beta blockers is the absolute first line, TEVAR is increasingly used in appropriate chronic cases to promote favorable aortic modeling.
Question 15. Which feature does not identify renovascular hypertension? Answer E, onset at the age of 45. A young adult onset, multi-drug refractory status, accelerated onset, and unexplained renal impairment are all classic red flags. Age 45 is squarely in the middle of standard essential hypertension onset, so it's a very weak clue. Question 16. A 72-year-old woman in severe heart failure on heavy pressors develops abdominal pain out of proportion with minimal vessel calcification, which is true. Answer C, treatment is directed at increasing cardiac output and circulatory support. This is non-occlusive mesenteric ischemia, or NOMI. There's no physical clot to revascularize. The intense splanchnic vasoconstriction is a pure hemodynamic problem. You fix it by fixing the flow.
Okay, section 6. Let's see how all this builds into our rapid-fire exam pearls section. It's time to lock in this high-yield knowledge.
Rapid review, part 1. Let's go. Stroke's major risk. Hypertension is massive. What about AKS? Criteria. Remember, asymptomatic, 60% or more, with periop stroke risk under 3%. Moving to NASIT, symptomatic, 70% or more, gets strong CEA benefit, giving you a 17% absolute risk reduction. Now for CEA nerve injury, always think hypoglossal nerve. Which CEA vein gets ligated? The facial vein. What is the ICA's first intracranial branch? That's the ophthalmic artery. And the ECA's first branch? The superior thyroid. Next up, symptomatic 80% stenosis. Definitely do a CEA. What about carotid stenting? That's for high-risk CEA patients only. Remember, contralateral ICA occlusion alone isn't enough for stenting. Carotid stent bradycardia? It's carotid bulb stretch, causing a vagal response. The AAA risk factor exception? Diabetes. Finally, the major AAA diagnostic weakness, aortography totally underestimates the size.
And part 2. AA repair thresholds, 5.5 centimeters for men, 5.0 for women, or if it's symptomatic. Blue toe with a pulse, that's microembolization. Ischemic colitis with transmural necrosis, emergent resection. Hypogastric occlusion leads to pelvic ischemia, but definitely not small bowel. Abdominal compartment syndrome, distended, uric, high airways, you must decompress immediately. Aortic wall degeneration, it happens mainly in the medial layer. Endoleak I, attachment. Endoleak 2, branches. Endoleak 3, component separation. Endoleak 4, porosity. Endoleak 5, endotension. How about EVAR? Great short-term, but no long-term survival advantage. Descending TAA, watch it safely until 6 centimeters. Type A dissection, ascending means emergent open repair. Type B dissection, distal means medical therapy, maybe TVAR. Renovascular HTN, think young, abrupt, and resistant. And finally, NOMI, low flow without occlusion, you absolutely must optimize that circulation. So diving into MCQ 1, we've got a 55-year-old female with a history of hypertension and smoking, and she shows up in the ER with severe pain in her left foot. Now, what examination finding would make you highly suspicious of an embolic event rather than just progressive atherosclerotic disease? The right answer here is B, palpable pedal pulses in the right foot and absolutely no history of claudication. Why? Well, think about it. Acute limb ischemia in a patient who has completely normal pulses in the opposite leg and zero claudication history is a massive red flag for an embolus. Chronic PAD usually gives you systemic clues, right? Like hair loss or diminished pulses elsewhere. So your key exam pearl is this. Normal contralateral pulses plus no prior claudication equals a super high suspicion for an embolus. All right, moving on to MCQ 2. Picture a 47-year-old guy, a lawyer, with a history of smoking, diabetes, hypertension, and hyperlipidemia. He's getting right calf claudication after about 6 blocks of walking, but he specifically says these symptoms do not hinder his desired activities. His ABIs are 0.6 on the right and 1.1 on the left. What's our initial management? You want to go with B, risk factor modification and structured exercise. Since his intermittent claudication isn't really lifestyle limiting, the initial approach has to be strictly conservative. We're talking smoking cessation, dialing in his diabetes and blood pressure, lipid management, and a solid exercise program. We only reserve revascularization for when symptoms actually start limiting their lifestyle despite those medical therapies.
Okay, MCQ 3. You've just finished up a femoral embolectomy on an AFib patient who came in with an 18-hour history of acute left leg pain, calf weakness, and numbness. The pedal pulses are finally palpable again, but you notice the calf muscle is really tense. What's your next move? The answer is C, perform 4-compartment calf fasciotomies immediately. Here's the deal. Prolonged acute limb ischemia, we're talking more than 6 hours, followed by revascularization, can cause massive reperfusion edema inside those closed fascial compartments. A tense calf is a glaring sign of acute compartment syndrome, and just because those pulses came back, there's no way that rules it out. You've got to act fast.
Now, MCQ 4 brings up a fantastic point about systemic risk. We have a 51-year-old male smoker with type 1 diabetes, hypertension, heart failure, and COPD, dealing with bilateral calf claudication for 6 months. His ABIs are 0.7 on both sides. You've counseled him on smoking, blood pressure, and glucose. What medication needs to be added right now? The answer is A, a statin. You know, peripheral arterial disease isn't just a leg problem, it's a direct manifestation of systemic atherosclerosis. These patients carry a huge risk for major cardiovascular events. Getting them on a statin is absolutely crucial to reduce mortality, and that priority easily outweighs just throwing symptomatic medications at them right off the bat. For MCQ 5, our last one in this chapter, a 19-year-old male is brought in after a head-on motor vehicle collision. His left knee is visibly deformed, he's in severe pain, and there's no palpable pulse in that left foot. X-rays confirm a posterior knee dislocation. What is the absolute next step? The correct answer is C. Perform a reduction of the left knee dislocation with sedation right there in the ER. The vital takeaway here is that knee dislocations notoriously cause popliteal artery compression. You have to do an immediate reduction first because, frankly, that mechanical compression might be 100% reversible. You only reassess the vascular status after you've popped that knee back into place. All right, let's pivot over to Chapter 29 and see how we can build out our knowledge of venous and lymphatic disease. Starting off this section with MCQ 1, a 72-year-old man comes in with 3 days of right leg swelling and a venous duplex confirms a proximal DVT. Which of the provided statements is actually true regarding DVT? It's D. Male gender is an independent risk factor for DVT. Why? Well, we know that clinical examination alone is notoriously bad for diagnosing DVTs, which is exactly why we rely on the duplex scan. Plus, the vast majority of patients have at least one identifiable risk factor, which effectively rules out the other options you'll see on the board. Moving to MCQ 2, a 65-year-old female is back for follow-up on a venous ulcer. She had a GSV radiofrequency ablation about a year ago for saphenofemoral reflux. Today, you check it out, and the ulcer is beautifully healed. What's her CAP classification? The answer is A, C5 East ACE PR. Let's break that alphabet soup down really quick. C5 stands for a healed venous ulcer, EASE means secondary etiology, ACE is for superficial venous involvement, and PR stands for reflux. Always remember, C5 means healed, while C6 would mean you're still dealing with an active ulcer. Now look at MCQ 3. Imagine you're advising a hospital task force on DVT prophylaxis, and you recommend low-dose subcutaneous heparin. A hospital admin asks, well, exactly how effective is this? Your answer? Low-dose unfractionated heparin reduces the risk of DVT by 50 to 70%. It is just a highly effective pharmacologic method of VTE prophylaxis. It literally cuts the DVT risk in half, if not more. For MCQ 4, let's say you perform a radiofrequency ablation of the right greater saphenous vein. 7 days later, a routine duplex shows a thrombosed GSV. But here's the catch. The clot is propagating straight into the common femoral vein. What's the appropriate treatment? You want D, enoxaparin with a bridge to Coumadin therapy for 3 months. The logic here is straightforward. A superficial thrombus that extends into the deep system, like the common femoral vein, has to be treated as a full-blown proximal DVT. And since it was provoked by your recent procedure, a standard 3-month course of anticoagulation is the way to go. In MCQ 5, neurosurgery consults you to drop in an IVC filter before a major spine surgery because the patient is going to be non-ambulatory for 7 days. They ask you, which of the following are potential complications of this filter placement? Filter fracture, embolus, DVT, or hematoma? The answer is E, all of the above. IVC filter placement is an invasive vascular procedure, plain and simple. Every single one of those listed complications, plus things like migration or access site bleeding, are well-documented, very real risks. Rounding out this chapter with MCQ 6, a 43-year-old female is diagnosed with a peroneal vein DVT, but she is completely asymptomatic. What's the correct recommendation here? The answer is C, a repeat ultrasound in 1 to 2 weeks. Remember, the peroneal vein is a distal, below-the-knee vein. When you have an isolated distal DVT that isn't causing any symptoms, the standard of care is actually serial duplex surveillance, rather than just jumping straight to immediate anticoagulation. And now, for our final sprint, let's dive into Chapter 30 covering hemodialysis access. Let's keep this momentum going. Kicking off our access section with MCQ 1, what is the appropriate flow rate for adequate hemodialysis? The target you're looking for is D, 200 to 500 milliliters per minute. This specific flow window is exactly the sweet spot required to achieve adequate clearance on the hemodialysis machine. For MCQ 2, we need to pinpoint the most common cause of AV graft dysfunction. The answer? C, stenosis. This is almost always related to pseudointimal hyperplasia, which slowly but surely impairs the flow, and, if you leave it untreated, eventually leads to outright thrombosis. So whenever an AV graft starts acting up, you should always be thinking stenosis first.
In MCQ 3, what's considered the adequate timeframe for dialysis access planning? The board's answer is B, 3 months.
The rationale for this 3-month lead time is that you have to allow plenty of time, not just for the surgical creation of the access, but for the actual biological maturation process of the vein before you can reliably and safely cannulate it. Moving to MCQ 4. What is the most common reason a patient has to abandon peritoneal dialysis and switch over to hemodialysis? The correct answer is D, peritonitis. Recurrent or just incredibly severe peritonitis is a massive complication of peritoneal dialysis. It frequently forces us to completely remove the PD catheter to clear the infection. Building right on that, let's look at MCQ 5. What is an acceptable initial empiric antibiotic regimen for that catheter-associated peritonitis we just talked about? The right answer is B, intraperitoneal cefazolin and gentamicin. You need empiric therapy that covers both sides of the spectrum. Gram-positive organisms are handled by the cefazolin, while your gram-negative coverage comes from the gentamicin. For MCQ 6, what's the most common site of flow-limiting stenosis in AV fistula? The answer is C, the juxta-anastomotic area. This occurs precisely because of the severe, turbulent, abnormal shear stress that happens right at that critical region where the artery and the vein are surgically joined. Now, MCQ 7, what is the maximum recommended depth beneath the skin surface to allow for easy AV fistula access? The correct answer is D, 5 millimeters. If an AV fistula matures beautifully, but it's sitting deeper than 5 millimeters, it is just too incredibly difficult for the dialysis nurses to safely cannulate. When that happens, we usually have to go back in for a secondary superficialization procedure. Let's clarify some definitions in MCQ 8. What is the correct terminology for the implanted synthetic tube placed during the creation of an AV graft? The answer is B, a non-autogenous conduit. By definition, an autogenous access uses the patient's own native vessels. An AV graft, on the other hand, utilizes a synthetic, manufactured tube, hence non-autogenous. Tackling MCQ 9, we're looking at salvage procedures for a patient dealing with vascular steel from a high-flow AVF access. The classic keyed answer here is B, banding the access. The reasoning is pretty elegant, actually. In a high-flow state, banding physically cinches down and reduces the diameter of the access. That directly decreases the amount of blood stealing from the hand, which immediately improves their distal perfusion. Finally, bringing it home with MCQ 10, which vascular access poses the absolute highest risk of infection. The correct answer is B, a non-tunnel dialysis catheter. See, tunnel catheters allow for tissue ingrowth into a little cuff, which acts as a physical barrier to microbes. Non-tunneled catheters completely lack that barrier, which predictably saddles them with the highest infection rates of any access type.
Starting off strong with MCQ 1, we've got a 33-year-old male with end-stage renal disease from polycystic kidney disease, and his mother actually comes forward wanting to donate a kidney. So what factors do we absolutely have to consider when evaluating potential live-in donors? Is it A, blood type, B, HLA type, C, comorbid conditions, D, psychosocial influences, or E, all of the above? Well, the answer here is E. A living donor assessment is the whole shebang. It requires a full medical workup, ABO compatibility, HLA histocompatibility, and a rigorous psychosocial evaluation. And hey, even if a donor is incompatible, options like paired kidney exchange might still be on the table. That's your very first major exam pro for today.
Okay, let's escalate the clinical stakes a bit with MCQ 2. You have a 65-year-old male who is just 3 days status post-orthotopic liver transplantation. You suddenly note new bilious output from his surgical drain, and his labs show persistent transaminitis. Should this prompt an evaluation for A, portal vein thrombosis, B, enterocutaneous fistula, C, hepatic arterial thrombosis, D, rejection, or E, all of the above? The diagnosis we must jump on immediately is C, hepatic arterial thrombosis. Think about it anatomically. The hepatic artery is the primary blood supply to the bile ducts, so early severe transaminitis combined with a bile leak, that literally defines this complication perfectly. It's a massive surgical emergency that can lead to rapid graft failure if you don't act fast.
Moving right along to MCQ 3, we are evaluating a 55-year-old male with cirrhosis from hepatitis C who has a few spots on his liver. Which of the following findings would absolutely preclude this patient from being considered for a transplant for hepatitis cellular carcinoma? Is it A, a single 4.5 centimeter lesion, B, 3 lesions measuring 2.5, 2, and 3.5 centimeters, C, 2 lesions measuring 2.5 and 2 centimeters, D, a single 3 centimeter lesion, or E, all are contraindications? The disqualifying factor here is B,
And why is that? It's all because of the Milan criteria. You need one tumor under 5 centimeters or up to 3 tumors, but each of those has to be under 3 centimeters. Option B has a lesion sitting at 3.5 centimeters, which instantly knocks this patient out of the criteria. Access issues bring us to MCQ 4. A 76-year-old female with a left-sided brachiobasilic AV fistula comes in with left upper arm swelling and pain. She's got good distal perfusion, but only a Dopplerable signal, meaning no palpable thrill. What is your very next step for venous hypertension with outflow stenosis? Options are A, percutaneous fistulogram with therapeutic dilation, B, open thromboembolectomy, C, anticoagulation, D, arm elevation, or E, watchful waiting. The absolute critical intervention to save this fistula is A. That venous outflow obstruction is exactly what's causing the limb swelling and pain, so the appropriate definitive step is a fistulogram with balloon angioplasty to open up that stenotic segment.
Let's look at long-term outcomes in MCQ 5. A 45-year-old female with type 1 diabetes and ESRD is asking you about a combined kidney-pancreas transplant. Which statement regarding whole-organ pancreas transplantation is actually true? Is it A, usually performed alone, B, the only therapeutic modality that can achieve long-term insulin independence, C, has a greater chance of requiring insulin than islet cell transplant, D, doesn't affect sequelae of diabetes, or E, all of the above? Option B is the winner here. This is a genuinely life-altering intervention because it provides long-term insulin independence. Plus, as a quick aside, about 95% of these are performed simultaneously with a kidney transplant, making that combo a massive game-changer for these specific patients.
For MCQ 6, we're faced with persistent transaminases in a 55-year-old male just 2 days post-liver transplant. His coagulation profile and bilirubin are totally normal. Which non-invasive test is most appropriate right now? A, MRCP, B, CT angiography, C, KUB, D, liver duplex ultrasound, or E, no further testing? The answer is D. This is a hard and fast rule. Whenever you see persistent transaminitis after a liver transplant, you must immediately assess vascular patency. A duplex ultrasound is your crucial, first-line, non-invasive test to check the flow in the hepatic artery, portal vein, and hepatic veins. Don't even hesitate.
Now, MCQ 7 really tests our ability to spot hidden complications. 3 days after a renal transplant, your patient develops graft swelling and a rising creatinine. But here's the kicker. They still have adequate urine output. Which study helps make the diagnosis? A, ultrasound, B, nuclear medicine scan, C, retrograde urethrogram, D, CT scan, or E, MRI? The human body is definitely full of surprises, but a urine leak post-transplant shouldn't be one of them. Option B is our crucial next step. You have to recognize this complication, which usually happens from an anastomotic leak or ureteral ischemia. A renal nuclear scan beautifully demonstrates the radiotracer extravascating right outside the urinary tract.
Looking at MCQ 8, we encounter a 45-year-old female with short gut syndrome. She just had her 3rd serious line infection this year. Which of the following are actual indications for an intestinal transplantation? A, frequent dehydration despite TPN, B, 2 or more serious line infections per year, a fungal infection, or a line sepsis shock, C, loss of 2 or more central venous access sites, D, parenteral nutrition-associated liver disease, or E, all of the above. The correct answer is E. Life-threatening complications of long-term TPN absolutely mandate that we consider intestinal transplant. If they are failing TPN, you have to move to the next level.
We're finishing up this first chapter with MCQ 9. A 55-year-old female with ESRD from Alport syndrome is being evaluated. Which of these factors should not raise her panel reactive antibodies, or PRA? A, previous pregnancy. B, history of blood transfusion. C, previous transplant. D, prior blood donation. Or E, all raise PRA. It sounds like a tricky question, right? But it's actually super straightforward once you break it down logically. Pregnancies, transfusions, and prior transplants all expose the recipient's immune system to foreign HLA, which drives up the PRA. But just giving your own blood away, that obviously doesn't expose you to anything foreign. Therefore, D is the correct exception here. Now, what's really interesting is our pivot into Chapter 32. The clinical stakes are shifting entirely as we dive into neonatal and pediatric surgical emergencies. Kicking off our pediatric scenarios with MCQ 1. We have a 10-year-old, 35-kilogram girl who is hypotensive after a high-speed crash. She has a positive seatbelt sign and a positive fast exam. Crucially, she hasn't improved after 2 fluid boluses. You are prepping to transfuse blood. What volume should you initially transfuse? A, 100 milliliters, B,
175 milliliters, C. 250 milliliters, D. 350 milliliters, or E. 475 milliliters. The vital math here, and you just have to know this, is that initial pediatric blood boluses are given at 10 milliliters per kilogram. So for a 35-kilogram kid, that equates to exactly 350 milliliters, making D our correct answer.
Shifting gears to the biliary tract for MCQ 2. A 4-year-old has chronic abdominal pain, jaundice, and a CT scan showing a cystic structure arising directly from the common bile duct but separate from the gallbladder. This is consistent with what type of choledochal cyst? A. Type 1, B. Type 2, C. Type 3, D. Type 4, or E. Type 5. The answer is B. A type 2 choledochal cyst is specifically defined as a true diverticulum, or a saccular cyst arising from the extrahepatic common bile duct. Make sure you commit that distinct classification to memory. It comes up all the time.
In MCQ 3, a 14-year-old boy is hemodynamically stable with a grade 2 splenic injury after an ATV accident. His family is super anxious and wants to know exactly how long he'll be admitted and how long he'll be restricted to light activity. Is it A, 24 hours and activity as tolerated, B, 2 days and 3 weeks, C, 3 days and 4 weeks, D, 4 days and 5 weeks, or E, 5 days and 6 weeks? Stable pediatric splenic injuries are managed non-operatively, but giving vital counsel to a worried family requires knowing the exact guidelines. For a grade 2 injury, the rule is C, 3 days of hospitalization and 4 weeks of light activity restrictions.
For MCQ 4, let's step right into the NICU. A newborn is in significant respiratory distress. Your attempts to pass an orogastric tube fail, and a chest X-ray shows the tube literally coiling in the upper chest. What additional workup makes the diagnosis? A. CT chest, B. Spinal ultrasound, C. Abdominal X-ray, D. CT abdomen and pelvis, or E. Upper GI with contrast. That coiling tube is a dead giveaway for esophageal atresia. But to rapidly determine our exact next steps, we immediately need an abdominal X-ray, which is option C, to see if bowel gas is present. If there's gas, that confirms a distal tracheoesophageal fistula.
Building perfectly on that exact scenario for MCQ 5, the plain abdominal X-ray does show air in the bowel, meaning there is indeed a distal TEF. However, when you do a bronchoscopy, it reveals no proximal fistula. So, this is classified as what type of tracheoesophageal fistula? Options are A through E. The answer is C, type C. I literally cannot stress this enough. Type C, which is proximal esophageal atresia with a distal tracheoesophageal fistula, accounts for 80 to 90% of all these cases. If you guess type C.
In MCQ 6, we're comparing abdominal wall defects. Which descriptor is associated with gastroschisis rather than other anomalies? A. Covered by peritoneal sac. B. Result of intrauterine vascular insult. C. High incidence of associated anomalies. D. Typically large defects. Option B is the standout here. Gastroschisis is thought to be the result of a right-sided intrauterine vascular insult. It does not have a covering sac, and it usually has far fewer associated anomalies. An omphalocele, on the flip side, is a midline folding defect that is totally covered by a sac and has a much higher rate of associated congenital anomalies.
MCQ 7 drops us into a super high-stress delivery room scenario. An 8-hour-old newborn is tachypneic with retractions, oxygen sats are dipping below 80%, and a chest X-ray shows herniated abdominal contents up in the left chest. What is your absolute next best choice? A. Emergent thoracotomy, B. ECMO cannulation, C. Intubation, or D. Bedside echocardiogram. This is classic congenital diaphragmatic hernia. Listen closely, this is a massive clinical pearl. You must stabilize the airway with intubation first, making C the correct answer. Never, ever rush an unstable neonate straight to a thoracotomy. Stabilize them first, repair them later.
For MCQ 8, we get to dive into the neuroanatomy of Hirschsprung disease. We know it results from a failure of neural crest cell development in the Mesner and Auerbach's plexi. But in what anatomical layers are these actually contained? Looking at the options mapping them out, the correct anatomical map is D. The Mesner plexus is located in the submucosa layer, while the Auerbach, also known as the myenteric plexus, is located deeper within the muscular layers.
All right, we are at our penultimate scenario, MCQ 9. We have a post-operative infant. 24 hours after a pyloromyotomy, the infant develops feeding intolerance,
mild tachypnea and abdominal distension, but is otherwise hemodynamically stable. What's the next step? A. Continue feeding. B. Change formula. C. Make NPO, start nasogastric drainage. Or D. Laparotomy. Recognizing this specific presentation as a mucosal perforation is absolutely critical to prevent things from spiraling. Because the infant is currently stable, the immediate correct management is C, making them NPO right away and starting NG decompression to completely rest that bowel.
And here we are, bringing us to our final challenge, MCQ 10. A young patient presents with severe abdominal pain and bilious emesis. You correctly suspect malrotation. Which of the following steps is not a common component of the LAD procedure? A. Reduction by counterclockwise rotation. B. Division of LAD bands. C. Appendectomy. Or D. Pexine the cecum to the peritoneal sidewall. The answer is D. Pexine the cecum, or cecopexy, is incorrect. We don't do that. The actual 4 sequential standard surgical steps of the LAD procedure are counterclockwise detorsion first, then dividing those bands, then broadening the mesentery, and finally, doing a prophylactic appendectomy.
High-stakes post-operative care and surgical indications. All right, starting right off with MCQ 1, we've got a 75-year-old female post-CABG. Her cardiac index is 1.7, she's normotensive, has absolutely no bleeding, and her CVP is sitting at 20. The correct answer here is B, start dobutamine. The clinical reasoning for this is straightforward but incredibly crucial. You see, a low cardiac index paired with a high CVP means her tank is completely full. She has adequate preload, her heart just isn't pumping effectively. So the right move is dobutamine to boost the contractility of that pump. Moving on to MCQ 2. Picture a 60-year-old male after a redo aortic valve replacement. He has 150 milliliters of bleeding in just the first 10 minutes, but, and this is key, he remains hemodynamically stable. The correct answer is E. Place a warmer on the patient and give protamine. Think about the human stakes here. A stable patient who's bleeding very early post-op most likely has a coagulopathy issue. You've got to correct those systemic issues, like hypothermia and residual heparin effect, first, before you even think about rushing them back to the operating room. Let's look at MCQ 3. We have a 55-year-old male with a STEMI and an ejection fraction of just 10%. He's being considered for an intra-aortic balloon pump. So, which echo finding is a contraindication? The correct answer is B, aortic insufficiency. This brilliantly illustrates the mechanics of an IABP. Because the balloon inflates during diastole to push blood into the coronaries, significant aortic regurgitation is an absolute contraindication. Diastolic inflation would literally just force blood backward and drastically worsen the regurgitation. No way we want to do that. On to MCQ 4. Which patient should be referred for a CABG? The correct answer is D, a 52-year-old male with a STEMI and a 90% proximal LAD lesion plus a 90% proximal RCA lesion. Notice the specific vessel locations here. Significant, severe multivessel coronary artery disease, especially when it involves the proximal LAD or the left main coronary artery, is the absolute classic trigger that heavily favors a bypass over stenting. Wrapping up the cardiac section with MCQ 5. A 59-year-old male has severe refractory heart failure despite an IABP and inotropes. Regarding cardiac transplantation, which statement is true? The correct answer is D. Pneumonia must be treated before transplantation. The massive exam pearl here, and I really want to emphasize this, is that any active infection is an absolute contraindication to transplantation until it is fully treated. If they need time to clear that infection, an LVAD can be used as a bridge, but the infection itself completely stalls the transplant pathway. All right, let's take a quick breath. Chapter 34, Lung and Mediastinal Diseases, Navigating Pneumothorax, Masses, and Resection Risk. Let's tackle MCQ 1 of this chapter. Which patient with a small pneumothorax can initially be managed by observation alone? The correct answer is B, a 62-year-old teacher with a small pneumothorax on room air. When approaching this kind of problem, just remember that stable, asymptomatic, first-time occurrences in low-risk patients don't immediately need chest tubes. Observation is perfectly safe and highly indicated here. For MCQ 2, we have a mechanically ventilated patient developing worsening hypoxia, hypotension, and markedly decreased breath sounds on the right. What's the next step? The correct answer is B, needle decompression. This is your classic tension pneumothorax with hemodynamic instability. The absolute rule here, immediate decompression. You never ever wait for a chest x-ray in an unstable tension pneumothorax. Now, what's really interesting about this next scenario, MCQ3, is how clearly it lays out Light's criteria. We have a patient with hepatitis C cirrhosis who has a recurrent right-sided pleural effusion consistent with hepatic hydrothorax. Which finding is expected? Answer A, pleural fluid protein is 2.0. A hepatic hydrothorax is a transudative effusion, and a transudate means the pleural to serum protein ratio is less than 0.5. And that reflects a low protein content, exactly as we're seeing here.
Moving to MCQ4, a 35-year-old male has an anterior mediastinal mass with elevated AFP and elevated beta-HCG. What's the treatment? The correct answer is D, chemotherapy followed by surgery. The diagnostic pathway here is completely dictated by those tumor markers. Elevated markers point directly to a non-seminomatous germ cell tumor. For these, the standard of care dictates upfront systemic chemotherapy first, followed by surgical resection of any residual mass.
In MCQ5, a 70-year-old patient has an incidentally discovered 3-centimeter peripheral right upper low pulmonary mass. The correct next step is B, a PET scan. I really want you to pay close attention to that 3-centimeter threshold. A mass greater than 3 centimeters is considered malignant until proven otherwise. This size demands an immediate malignancy workup, and a PET-CT is absolutely essential to assess metabolic activity and for initial staging.
Next up, MCQ6. A 65-year-old smoker has lung adenocarcinoma, and the PET-CT is concerning for T1N2M0 disease. The appropriate next step. Answer A, mediastinoscopy or EBIS. So, the crucial point here is that imaging simply isn't enough when you suspect N2 nodal disease. Before embarking on definitive treatment, you absolutely must have tissue confirmation, which you get via an endobronchial ultrasound or mediastinoscopy. Concluding the lung chapter with MCQ 7. Which lung function evaluation indicates the highest risk for undergoing a lobectomy? Correct answer is C, an FEV1 of 20% predicted and a VO2 max of 12 milliliters per kilogram per minute. These specific cardiopulmonary metrics are major red flags. A very low FEV1 combined with a low VO2 max equals terribly poor cardiopulmonary reserve, and that translates directly into high operative mortality.
Okay, brief mental breather. Chapter 35, Breast. Managing malignancy, mastitis, and benign conditions. Let's move to MCQ1 and see how this builds a really interesting clinical paradox. Which patient undergoes radiation therapy as part of her breast cancer management? The correct answer is C, a 32-year-old pregnant woman with a T1 tumor at 33 weeks. But here's the catch. While surgery is totally okay during pregnancy, radiation is strictly deferred until postpartum. She needs it as part of her overall plan, but we absolutely delay it for the safety of the baby. For MCQ2, radiation therapy after a partial mastectomy primarily improves what? The correct answer is A, rates of local recurrence. It is critical to state definitively that the primary oncologic benefit of adding radiation to a lumpectomy is purely about local control. It decreases ipsilateral local recurrence, but it's not the primary driver of overall systemic survival. Moving quickly to MCQ3, what is the first-line pharmacologic treatment for mastalgia, or breast pain? Correct answer, D, topical NSAIDs. This is crisp and simple. Before you jump to complex hormonal therapies, just remember that this simple, targeted topical therapy is your standard go-to board answer for first-line pharmacologic treatment. MCQ4 gives us a 32-year-old woman 2 weeks postpartum who develops lactational mastitis. What's the next step? Answer B, antibiotics and increased breastfeeding frequency. This is a vital mini-narrative to reassure patients. Stopping breastfeeding is entirely the wrong answer. You treat the infection with antibiotics, sure, but emptying the breast is actually therapeutic and clears the stasis. Now for MCQ5, regarding breast cancer in men. The correct statement is A, it's associated with a BRCA2 mutation in about 5% of cases. I want to highlight this surprising but absolutely crucial genetic link. When you see male breast cancer, it is usually invasive ductal carcinoma, and your mind should heavily point toward testing for that BRCA2 mutation. For MCQ6, I want to burn a massive, memorable rule of thumb directly into your memory. The question asks for the most common cause of pathologic nipple discharge. The correct answer is C. Just remember this quote. Pathologic nipple discharge classic cause is intraductal papilloma. Lock that phrase in, guys, because it will absolutely show up on your exams. Almost done. MCQ 7, a 75-year-old man develops bilateral breast enlargement. He's on multiple medications and has chronic kidney disease. What's the next step? Correct answer, C. Call his primary care physician.
Before jumping to core needle or punch biopsies for this older gentleman, the logical, standard of care step is a systemic medication review. Gynecomastia requires ruling out pharmaceutical or systemic causes first.
Finally, MCQ 8. A 44-year-old woman has a screening mammogram classified as BRADS3, which means probably benign. How should she be counseled? The correct answer is B. Return in 6 months for repeat mammography. The absolute rule here is that a BRADS3 categorization mandates a short interval follow-up imaging, classically at 6 months. We've conquered all 20 questions, but I'll leave you with this final provocative thought. If BRADS3 dictates a rigid 6-month timeline,
Skin and soft tissue tumors. Get ready to really test your clinical instincts here. MCQ 1 asks, for which of these patients is a sentinel lymph node biopsy, or SLNB, indicated? Okay, here are your options. Is it the 55-year-old male with a 0.6 millimeter thick melanoma of the back with no ulceration and 3 mitoses per millimeter squared? The 20-year-old female with melanoma in situ of the right back? The 66-year-old male with a 1.2 millimeter thick acromelanoma of the left lower extremity with left inguinal adenopathy, the 54-year-old female with a 3.2 millimeter thick right upper extremity melanoma with 2 pulmonary metastases, or, finally, the 35-year-old male with a 1.4 millimeter thick melanoma of the back with no ulceration or mitoses. The answer is that last one, E. Why? Well, melanoma is less than 0.75 millimeters, and melanoma in situ just don't require an SLNB. If there is clinically detectable adenopathy, like in option C, that warrants a full lymph node dissection, and SLNB absolutely has no role in metastatic disease, like option D. So keep this pearl in mind for your rounds. SLNB is indicated for melanoma greater than 1 millimeter in thickness in the absence of metastases or clinical adenopathy. Moving right along to MCQ 2. A 68-year-old male presents with a growing, smooth, hypopigmented 2-centimeter lesion on the right cheek that occasionally stings and bleeds. What's the best next step? Are we looking at Mohs microsurgery, an excisional biopsy, an FNA, a punch biopsy, or a shave biopsy? The correct answer is a punch biopsy. The reasoning here is that while Mohs microsurgery might be the right move later, you can't do it until after you have a diagnosis. Excisional biopsies aren't great for cosmetically sensitive areas like the face, FNAs are really for soft tissue masses, and shave biopsies, they're notorious for being bad at assessing depth. So the pearl is this: diagnosis must precede Mohs microsurgery, and a shave biopsy is completely suboptimal when the depth of the lesion actually matters.
Now, for a really interesting clinical scenario. MCQ 3. A 38-year-old firefighter is referred to you with a non-healing wound arising after a burn injury 4 months ago. He has controlled type 2 diabetes and smokes a pack weekly. He's got a 4-centimeter linear scar with a 1.5-centimeter central ulcer, some serosanguineous drainage, palpable pulses, but absolutely no warmth or erythema. What is the best course of action? Are we prescribing topical mupirocin, increasing his insulin dose, advising smoking cessation, obtaining ankle brachial indices, or biopsying the wound edge? The correct move is to biopsy the wound edge. This chronic, non-healing wound sitting right inside a burn scar is highly concerning for a marginal ulcer. Since there's no clinical sign of infection, antibiotics aren't needed, and honestly, his well-controlled diabetes and minor smoking habit just aren't the primary culprits here. So your crucial takeaway: a chronic, non-healing wound arising in a burn scar should always raise immediate concern for a marginal ulcer, and it warrants a biopsy.
Let's see how this builds our oncology knowledge with MCQ 4. A 44-year-old male had a punch biopsy showing a 1.8 millimeter thick, superficial spreading melanoma on his shoulder. There is no clinical adenopathy. What's the most appropriate management? Are we doing a wide local excision with 1 centimeter margins, a wide local excision with 2 centimeter margins, a WLE with 1 centimeter margins plus SLNB, a WLE with 2 centimeter margins plus SLNB, or a WLE with 2 centimeter margins plus a left axillary lymph node dissection? The answer is D, the WLE with 2 centimeter margins plus SLNB. A 1 centimeter margin is completely insufficient for melanomas thicker than 1 millimeter. You need that 2 centimeter margin plus the SLNB since there's no clinical adenopathy present. For MCQ 5, we have a 55-year-old female with a new 4 millimeter brown, homogeneous, round macular lesion with a slightly indistinct border on her calf. What is the best management here? Are we observing, doing a shave biopsy, an excision with 1 centimeter margins, an excisional biopsy, or using topical 5-fluorouracil? The answer is an excisional biopsy. Observation is flat out wrong because new nevi after age 40 must be considered potentially malignant. You need a definitive diagnosis. The exam pearl to log away in your brain: a new nevi after age 40 should be considered potentially malignant until proven otherwise.
Now notice the stark contrast in these next two scenarios. MCQ 6. A 46-year-old male has a 1 centimeter mobile, soft, round mass on his left posterior neck, which he's noticed since childhood. No symptoms whatsoever. Best management. Are we observing, doing a core needle biopsy, surgical excision, an incisional biopsy, or getting a CT of the head and neck? The answer here is simple observation. It's small, mobile, soft, and hasn't grown an inch. These are the classic hallmarks of a benign lipoma. Contrast that laid-back approach with MCQ 7. Which melanoma patient is most appropriate for a radiation oncology referral? Is it the 63-year-old with a 1.1 millimeter melanoma and a negative SLNB? The 24-year-old with melanoma in situ post-MOS? The 66-year-old with a 1.9 millimeter melanoma post-left groin dissection with 3 positive lymph nodes? The 73-year-old with a 2.8 millimeter melanoma and pulmonary mets, or the 35-year-old with a 1.4 millimeter melanoma with a positive SLNB but negative completion dissection? The answer is the 66-year-old with 3 positive lymph nodes. Radiation is specifically indicated for loco-regional control in patients with regional disease. It is not for primary alone, and it's not for widely metastatic disease.
Moving to MCQ 8, a 42-year-old female presents with a 2 by 4 centimeter enlarging right upper extremity mass. She has no skin changes, but her grip strength on that side is weak. What's the best management? Are we looking at radiation therapy, obtaining an MRI and a chest CT, an incisional biopsy, excising with wide margins in SLNB, or an FNA? The answer is absolutely obtaining an MRI and a chest CT. This clinical presentation screams soft tissue sarcoma with neurovascular involvement. The pearl you need to know is that for any suspected soft tissue sarcoma, you need an MRI to evaluate the primary disease and a CT of the chest for staging. Yes, a cord tissue biopsy will be needed eventually, but imaging and staging must always precede any intervention.
Next up, MCQ 9. A 63-year-old female has had a left axillary lump for 4 months. She has a completely normal mammogram and no skin lesions or fevers. Next step. Are we doing a core needle biopsy, a PET scan, observing for 1 month, starting 10 days of Keflex, or initiating radiation? The answer is a core needle biopsy. This is adenopathy of unknown origin, which is highly concerning for occult melanoma. You literally cannot do anything else until you get a tissue diagnosis first. And that brings us to MCQ 10, which asks, what is the most important prognostic factor for soft tissue sarcomas? Is it the histologic subtype, patient age, comorbidities, the amount of necrosis, or the tumor grade? The answer is grade. Lock this undeniable exam pearl in. Grade is the single most important prognostic factor in soft tissue sarcomas, period.
This brilliantly illustrates our next points on sarcoma management. MCQ 11. A 73-year-old female has a left distal femoral malignant fibrous histosarcoma that is right up against the artery. Next step? Are we proceeding with a wide local excision, an amputation, getting a chest CT, doing isolated limb perfusion, or starting radiation? The answer is a chest CT. Just like we talked about earlier, always stage a soft tissue sarcoma before starting any treatment. Now look at the pure surgical drama in MCQ 12. A 44-year-old male is in the OR for a large retroperitoneal liposarcoma. Intraoperatively, you find it completely encases the left renal artery and vein. His preoperative labs were totally normal. What do? Are you debulking the tumor, placing clips and closing the patient up for chemo, performing a resection en bloc with the left kidney, or resecting with positive margins and placing a nephrostomy? The answer is to perform a resection en bloc with the left kidney. En bloc resection with the involved organ greatly enhances survival, and since his overall kidney function is totally normal, it's definitively the right move.
What's really interesting about these next two cases is the stark contrast in tumor aggression. MCQ 13 asks for the worst prognostic factor in Merkel cell carcinoma. Is it patient age, tumor size, mitotic index, microscopic nodal disease, or lymphovascular invasion? The answer is lymphovascular invasion. If you see that on the path report, it portends the absolute lowest survival in Merkel cell carcinoma. In total contrast to that, we have MCQ 14. A 67-year-old presents with a 2.2 centimeter basal cell carcinoma of the shoulder. Next step, are we ordering a chest CT, doing a resection with 0.4 centimeter margins, performing Mohs surgery, resecting with 1 centimeter margins and SLNB, or giving radiation? The answer is resection with 0.4 centimeter margins. Basal cell is locally invasive, sure, but it essentially never metastasizes. Therefore, a resectable lesion like this just needs a straightforward simple excision with 0.4 centimeter margins.
Wrapping up the oncology section with MCQ 15.
A 61-year-old male has a 6-centimeter squamous cell carcinoma of the thigh and a confirmed solitary 4-centimeter liver metastasis. A PET scan shows avidity only in these two specific spots. For management, are we looking at resection of both lesions, excision of the thigh with radiation to the liver, cryotherapy for the thigh with radiation to the liver, systemic chemotherapy, or topical imicamod for the thigh with resection of the liver? The answer is resection of both lesions. Both the primary SCC and solitary metastases should be surgically resected whenever possible because doing so actually offers a high chance of a cure. Okay, take a breath because we are pivoting right into our next major topic.
Moving right along to Chapter 37, Fundamentals of Laparoscopic, Robotic, and Endoscopic Surgery. Let's hit these minimally invasive principles fast. For MCQ 1, which of the following is an absolute contraindication to laparoscopic surgery? Is it a small bowel obstruction, morbid obesity, peritonitis from a perforation, uncontrolled coagulopathy, or hypothermia? The answer is uncontrolled coagulopathy. That is a hard, non-negotiable stop for laparoscopy. MCQ 2. Intra-abdominal pressure during laparoscopic surgery should be closest to 2, 6, 12, 18, or 25 millimeters of mercury. The answer is 12. The core pearl to remember is that pneumoperitoneum should be strictly maintained in that 12 to 15 millimeters of mercury range.
Now pay very close attention to this next one. It's a terrifying clinical scenario. MCQ 3. After insufflating with a varus needle, a trocar is inserted just inferior to the umbilicus, and it is immediately followed by a rush of bright red blood. Next step, should you keep the trocar in place and perform a laparotomy? Resume insufflation and insert the laparoscope to see what's happening, apply manual pressure, remove the trocar and perform a laparotomy, or abort the operation entirely and go to IR. The absolute life-saving answer is to keep the trocar in place and perform an immediate laparotomy. Whatever you do, do not pull that trocar out. Leave it exactly where it is to tamponade the bleeding and guide you to the injury, and open the patient up immediately for this major vascular injury.
Next up, MCQ 4 compares our modalities. What's a core benefit of robotic surgery over traditional laparoscopy? Is it reduced operative time, ergonomic advantages to the surgeon, reduced blood loss, improved haptic feedback, or an expanded field of view? The answer is ergonomic advantages to the surgeon. That is the most consistently well-documented benefit here. And for MCQ 5, what is a normal physiologic effect of a pneumoperitoneum? Among increased preload, metabolic alkalosis, increased pulmonary compliance, decreased intracranial pressure, and decreased glomerular filtration rate, the answer is a decreased GFR. All that increased intra-abdominal pressure transiently decreases your GFR, though it doesn't typically cause any permanent kidney injury.
Finally, we are bringing it home with Chapter 38, Hernia Diagnosis and Repair.
We are officially in the home stretch, folks. These are the absolute bread and butter rules every surgeon needs to know. MCQ 1 asks what is true regarding inguinal hernias. Is it that they are more common in women, rarely bilateral, that direct is more common than indirect, that recurrent hernias are more likely to be direct than indirect, or is there simply no difference in recurrence based on repair type? The true statement is D. Recurrent hernias are more likely to be direct than indirect. While indirect hernias are the most common overall, if a hernia actually recurs, it is much more likely to be a direct one. MCQ 2. An 83-year-old thin woman with no prior surgical history presents with a small bowel obstruction and pain with medial thigh rotation. She has absolutely no palpable groin hernia. What's the diagnosis? Are we dealing with a femoral, inguinal, spigelian, obturator, or an adhesive SBO? The answer is an obturator hernia. That specific pain with internal thigh rotation is the classic Haus-Ship-Romberg sign.
This next one is a flat-out surgical emergency. MCQ 3. A 35-year-old woman has a one-day history of abdominal pain, a tender right groin bulge with erythema, a fever of 38.5, and a heart rate of 115. Next step, are we getting an ultrasound, a CT scan, proceeding with admission for an NG tube and IV fluids, performing laparoscopic repair, or doing an urgent open inguinal hernia repair? The answer is an urgent open repair. She has a strangulated hernia. You absolutely do not delay for any imaging in this scenario. An open repair is preferred so you can properly evaluate the bowel to see if it needs resection.
MCQ 4. A 28-year-old, highly active man has a 5-centimeter incisional hernia from a past trauma laparotomy. What is the preferred repair method? Are we doing open with intra-abdominal synthetic mesh, laparoscopic with synthetic mesh, open repair with retrorectus placement of synthetic mesh, laparoscopic with barrier-coated mesh, or open with retrorectus biologic mesh? The answer is open repair with retrorectus placement of synthetic mesh.
For a young active patient like this, midline reapproximation with a retrorectus synthetic mesh is going to provide the most functional abdominal wall and the lowest possible risk of recurrence.
And our final question, MCQ 5. A 70-year-old man with CHF and a prior open prostatectomy has a symptomatic right inguinal hernia and a small, completely asymptomatic left one. What is the management? Are we doing bilateral open repair without mesh? Laparoscopic right with mesh and evaluate the left? Laparoscopic right and cover the left? Open right with mesh and watchful waiting for the left? Or just watchful waiting for both? The answer is open right with mesh and watchful waiting for the left. His CHF and that prior prostatectomy dictate that an open approach is mandatory here, not laparoscopic. You repair the symptomatic right side with mesh, and you can safely use watchful waiting for that asymptomatic left side.
So the crucial point we end on is perfectly summarized right here on the screen. Symptomatic hernias get repaired. Asymptomatic ones can often safely undergo watchful waiting.
Chapter 39, Adrenal and Pituitary Glands. Here's our first scenario. We've got a 6-month-old female whose father has MEN2B, and she tests positive for the RET proto-oncogene mutation. Her calcitonin levels are currently undetectable. So what should we do? Should we A, monitor calcitonin and operate when she's 20? B, total thyroidectomy at age 5? C, total thyroidectomy within the next several months? D, wait until she's 1 year old? Or E, total thyroidectomy at age 20? The answer is C. You must perform a total thyroidectomy within the next several months. And the reasoning here is completely non-negotiable. MEN2B patients absolutely require a prophylactic thyroidectomy within their first year of life because medullary thyroid carcinoma is incredibly aggressive and can actually be present right at birth, even with undetectable calcitonin. You just don't wait. So here's your first exam pearl to lock in. MEN2B means prophylactic total thyroidectomy within the first year of life. Okay, moving right along to question 2. Which of the following is not consistent with finding a cortisol level less than 20 micrograms per deciliter on corticotropin stimulation testing? Your options are A, hypokalemia, B, hypoglycemia, C, hypotension, D, fever, or E, emesis. The correct answer is A, hypokalemia. See, a cortisol level under 20 indicates adrenal insufficiency. And acute adrenal insufficiency triggers a whole host of issues. We're talking hypoglycemia, hypotension, fever, emesis, and crucially, hyperkalemia, not hypokalemia. So your exam pearl here is simple. Adrenal insufficiency leads to hyperkalemia. Next up, we have a 32-year-old otherwise healthy guy with an incidental 4-centimeter non-functional left adrenal mass that was just found after a car crash. All his biochemical tests are completely normal. What's our next step? A, plasma aldosterone, B, repeat CT in 6 months, C, laparoscopic left adrenalectomy, D, MRI, or E, RET testing. The answer is C, laparoscopic left adrenalectomy. Why? Well, because a healthy young patient with a non-functional mass between 4 and 6 centimeters needs to have that unilaterally removed. He isn't hypertensive, so we skip the aldosterone testing. He's a fantastic surgical candidate, so there's absolutely no need for an MRI, and routine RET testing is just useless here. Exam pearl, healthy young patient plus a non-functional 4 to 6 centimeter adrenal mass equals laparoscopic unilateral adrenalectomy. Now, what's really interesting about this next diagnostic dilemma is the clinical logic you have to apply. We've got a 50-year-old on a multi-drug regimen for persistent hypertension. He's got hypokalemia and high aldosterone. Now, imaging shows 2 benign-appearing masses, a 1-centimeter one on the left and a 6-centimeter one on the right. What is the next step? A, right adrenalectomy, B, medical management alone, C, repeat imaging, D, bilateral adrenal vein sampling, or E, bilateral adrenalectomy. The answer is D, you must perform bilateral adrenal vein sampling. We already know he has an aldosterone-producing adenoma, but imaging literally cannot tell you which of those 2 masses is actually hypersecreting the hormone. Adrenal vein sampling will lateralize the source and direct your surgery, which helps you avoid a bilateral adrenalectomy and a lifetime of permanent adrenal insufficiency. So your exam pearl, bilateral adrenal masses with suspected aldosteronoma always require adrenal vein sampling to lateralize the source.
Last one for this chapter, guys. A 65-year-old female with a recent coronary stent presents with an incidental 8-centimeter right adrenal mass containing macroscopic fat on her CT scan. Her biochemical workup? Completely normal. What are our management options? A, repeat CT, B, MRI, C, immediate adrenalectomy on Plavix, D, adrenalectomy off Plavix, or E, no further intervention. Answer E is correct, no further intervention. That macroscopic fat on the CT scan, that's the dead giveaway. It is highly characteristic of a benign adrenal myelolipoma. And unless it's causing symptoms or there's a really high risk of retroperitoneal hemorrhage, clearly identified myelolipomas just don't require repeat imaging or surgery. Exam Pearl, macroscopic fat on CT means adrenal myelolipoma. Leave it alone unless it's symptomatic.
Okay, take a quick mental breather, moving right into Section 2, Chapter 40, Thyroid and Parathyroid Glands. Let's keep this momentum going. First up in this section, a 56-year-old man presents with a small, slow-growing, painless right neck mass. He's totally asymptomatic and normotensive. What is the very first diagnostic study that you should perform? A. Ultrasound. B. Serum TSH level. C. FNA. D. CT scan. Or E. Thyroid scintigraphy. The answer is B. A serum TSH level. Why? Because before you go sticking needles into a thyroid nodule, you absolutely need non-invasive laboratory testing to determine the patient's thyroid functional status. Hyperthyroid patients generally skip the FNA, whereas euthyroid or hypothyroid patients move on to ultrasound and then FNA. So, Exam Pearl. The initial workup for any thyroid nodule always starts with a serum TSH level.
All right, we have a real clinical urgency in this next scenario. A 64-year-old woman is in the ER with vague abdominal pain, confusion, and a short QT interval. Her serum calcium is a massive 15.2 milligrams per deciliter. What etiology does this suggest? A. Thiazide use. B. Secondary hyperparathyroidism. C. Parathyroid carcinoma. D. Single adenoma. Or E. Factitious hypercalcemia. The answer is C. Parathyroid carcinoma. Whenever you see a patient symptomatic from marked hypercalcemia, and we're talking usually 3 to 4 points above the normal limit, you must have a super high index of suspicion for carcinoma rather than just a simple adenoma. Exam Pearl. Marked symptomatic hypercalcemia should instantly make you think parathyroid carcinoma.
Next up, a 50-year-old male is 1 year post-total thyroidectomy and he's taking daily levothyroxine. What is the best method to monitor the adequacy of his replacement therapy? Is it A. Radioactive iodine uptake, B. Thyroglobulin, C. RT3U, D. Serum TSH level, or E. Total T4? The correct answer is D. Serum TSH level. TSH beautifully reflects the actual peripheral tissue effect of the thyroid hormone, which makes it the single most sensitive test we have for monitoring levothyroxine dosage. Exam Pearl. When you're monitoring levothyroxine replacement, always rely on the serum TSH. Let's look at a 72-year-old woman with primary hyperparathyroidism and a calcium of 13.6. Which biochemical abnormality might actually accompany her hypercalcemia? A. Metabolic alkalosis, B. Hyperphosphatemia, C. Hypochloremia, D. Hypermagnesemia, or E. Elevated alkaline phosphatase? The answer is E. Elevated alkaline phosphatase. And the reasoning here is that hyperparathyroidism drives osteoclastic bone resorption. This causes bone disease, which in turn spikes the alk phos. Remember, primary hyperparathyroidism typically causes a metabolic acidosis, not alkalosis, along with hypophosphatemia. Exam Pearl. Primary hyperparathyroidism with bone disease will show an elevated alk phos. And you know, this next one brilliantly illustrates why embryology actually matters in the OR. You're doing a neck exploration on a 63-year-old, you find normal right and left superior glands and a normal left inferior gland. So where's the most likely location for that missing right inferior parathyroid? A. Tracheoesophageal groove, B. Right thyroid, C. Superior thymus, D. Posterior mediastinum, or E. Pharyngeal mucosa. Answer C is correct, the superior thymus. The inferior parathyroids share an embryological origin with the thymus, so if they fail to descend properly during development, they are very often found embedded in the thymus or right near the thyrothymic ligament. Exam Pearl? Searching for a missing inferior parathyroid? Look near the thyrothymic ligament, or thymus. Demographics matter, folks. Which of these patients with thyroid enlargement is least likely to have thyroid cancer? A. A 5-year-old with an MEN family history. B. A 75-year-old with a solitary nodule. C. A 56-year-old with a radiation history. D. A 43-year-old woman with a multinodular goiter and tremor. Or E. A 14-year-old with a solitary nodule. The answer is D. Extremes of age, solitary nodules, radiation exposure, and a syndromic family history, those are all major red flags for malignancy. A multinodular goiter in a middle-aged woman is just far less concerning. Exam Pearl. Multinodular disease without other warning signs is reassuring compared to solitary nodules or high-risk demographics. Here's your classic hypothyroid presentation.
We have a 47-year-old woman with weight gain, fatigue, and muscle weakness. No prior surgery, no medications. Her TSH is extremely high, over 30. What's the most likely cause? A. Thyroid adenoma. B. Self-administered hormone. C. Papillary carcinoma. D. RAI administration. Or E. Hashimoto thyroiditis. The answer is E. Hashimoto thyroiditis. It is simply the most common cause of hypothyroidism in patients who don't have a history of thyroid surgery or radioactive iodine therapy. So exam pearl right there, most common cause of primary hypothyroidism without prior intervention equals Hashimoto thyroiditis.
Next up, a 65-year-old female is post-total thyroidectomy for papillary thyroid carcinoma. Which of these pathology features indicate tumor aggressiveness and a poor outcome? A. Tumor size over 4 centimeters. B. Macroscopic lymph node metastasis. C. Local capsule invasion. D. Poorly differentiated grade. Or E. All of the above. The answer is E. All of the above. Look, while papillary cancer generally has an excellent prognosis, it gets aggressive if it's over 4 centimeters, if it invades locally, has bulky nodes, or shows poorly differentiated histology. And keep in mind, age over 45 and male gender also worsen the prognosis. Exam pearl. Know the aggressive features of papillary cancer: size, invasion, nodes, and grade. All right, we have a 1-month-old infant. The father had an infant thyroidectomy, and there's a strong family history of pheochromocytomas. What is the most sensitive method for detecting medullary thyroid carcinoma risk in MN2 type syndromes? A. Genetic evaluation. B. Plasma CEA. C. Plasma catecholamine. D. Serum thyroglobulin. Or E. Serum calcium. Answer A is correct, genetic evaluation. Given this intense family history of MN2, testing for germline mutations in the RET proto-oncogene is the absolute gold standard to detect risk. Example, for an MN2 family history, you must mandate germline RET proto-oncogene testing.
Let's finish this chapter strong. A 34-year-old female has a large goiter, a tremor, and palpitations. What other features might also be present? A. Exophthalmos and pretibial myxedema. B. Suppressed TSH. C. Cold intolerance. D. Answers A and B only. Or E. All of the above. The correct answer is D. Answers A and B only. She has Graves' disease, which produces hyperthyroid symptoms alongside a suppressed TSH due to negative feedback. Exophthalmos and pretibial myxedema are completely pathognomonic for Graves. Cold intolerance? Well, that's a hypothyroid symptom. Exam pearl. Graves' disease presents with hyperthyroid symptoms, a suppressed TSH, and, uniquely, exophthalmos and pretibial myxedema.
All right, home stretch, Section 3, Chapter 41, Otolaryngology for the General Surgeon. Let's push through this final section.
First up in ENT, a 5-year-old healthy boy presents with a non-tender midline neck mass that moves vertically when he swallows. What diagnostic study must be performed before surgery? A. FNA, B. MRI, C. Ultrasound, D. CT, or E. EBV testing. The answer is C. Ultrasound of the neck. This is your classic thyroglossal duct cyst presentation, but here is the critical medical reasoning you can't miss. You must do an ultrasound first to ensure that this mass isn't the patient's only functioning thyroid tissue. Removing it blindly could cause permanent iatrogenic hypothyroidism, and you definitely don't want that. Exam pearl. Always use ultrasound to confirm normal thyroid tissue before excising a thyroglossal duct cyst. Talk about an absolutely terrifying acute scenario. A 45-year-old woman is in the PACU immediately following a total thyroidectomy. She develops stridor and desaturates. You check, and both vocal cords are paralyzed. What is the best care? A. Speech therapy. B. Nasal cannula. C. Temporary vocal cord injection. D. Thyroplasty. Or E. Tracheostomy. The answer is unequivocally E. Tracheostomy. Bilateral vocal cord paralysis creates a severe, immediate airway compromise that mandates an immediate tracheostomy to protect the airway. Things like speech therapy and injections, those are for unilateral injuries. Exam pearl. Bilateral vocal cord paralysis with airway compromise equals immediate tracheostomy.
Next up, a 12-year-old female has persistent bulky cervical lymph nodes despite a course of antibiotics. An FNA comes back suspicious for lymphoma. So what's the next step? A. Bilateral neck dissection. B. Selective neck dissection. C. Radiation. D. Core or excisional biopsy. Or E. Second FNA. The answer is D. Core or excisional biopsy. When lymphoma is suspected, an FNA just isn't going to cut it because you actually need to evaluate the tissue architecture for immunophenotyping and flow cytometry to direct the systemic treatment. Example, suspected lymphoma always requires a core or excisional biopsy.
So the crucial point in this next scenario is just knowing your basic epidemiology. A 40-year-old female has a slowly growing, painless cheek mass lying directly over the masseter muscle. What is the most common diagnosis for this parotid mass? A. Adenoid cystic carcinoma, B. Adenocarcinoma, C. Pleomorphic adenoma, D. SCC, or E. Warthin tumor. The answer is C. Pleomorphic adenoma. Parotid tumors are mostly benign, and the absolute most common benign tumor is a pleomorphic adenoma, which you treat with a superficial parotidectomy. Quick example: most common benign parotid tumor is a pleomorphic adenoma.
Here is a massive pitfall you have to avoid. A 25-year-old female presents with a deep neck mass that is splaying her carotids, and it's causing syncopal episodes. You suspect a carotid body tumor. What is the next step? A. FNA, B. Core biopsy, C. Watch and wait, D. Surgical resection, or E. Angiography with preoperative embolization. The answer is E. This is a highly vascular, symptomatic tumor. There is a strict golden rule here. Do not biopsy these tumors. Instead, you proceed directly to angiography with embolization prior to surgical resection to control the massive bleeding risk. Example: carotid body tumors mean no biopsy. If they're symptomatic, do angiography and embolization before surgery.
We made it to the final scenario. A 50-year-old smoker has a right tonsil mass and a right neck mass. You suspect metastatic squamous cell carcinoma to the neck. Next best step: A. Core or open biopsy, B. Watch and wait, C. Tonsil removal plus neck dissection, D. FNA of the neck node, or E. Chemoradiation. Answer D is correct. You absolutely must perform an FNA first. The reasoning here is critical. Doing an open or excisional biopsy of a cervical node with suspected metastatic SCC drastically increases the risk of distant metastases and local recurrence. Always start with an FNA. Final example: suspected metastatic cervical SCC means FNA first. Absolutely avoid open biopsy.
We'll be navigating through complex reconstructions, hidden traumas, and high-stakes wound management.
Let's look at MCQ 1. Picture this. An 83-year-old man gets a basal cell carcinoma excised from his cheek. He's left with a 3 by 3 centimeter defect, and the fat is exposed. So which skin grafting reconstruction minimizes long-term contracture? The answer is a full-thickness skin graft. Why? Well, it includes both the epidermis and the entire dermis. Sure, those elastin fibers cause it to recoil right when you harvest it, but once it's inset, you get minimal long-term contracture. Contrast that with split-thickness grafts, which can literally contract up to 40% during healing. For the face, you absolutely need that full-thickness graft to avoid distortion.
Moving to MCQ 2, we've got a 23-year-old guy coming in after a car crash. He has bilateral orbital ecchymosis and vision loss in his right eye. What is the absolute first step here? I know, your instinct is screaming to rush to an intraocular exam to save his vision, but the correct answer is always completion of the primary trauma survey. Facial trauma patients have a notoriously high incidence of C-spine and intracranial injuries. ABCs always come before the eye.
For MCQ 3, a 20-year-old gets a small cut over his third metacarpal after a bar altercation. X-rays show no fracture, but his finger hurts when he extends it. To minimize joint destruction, you've got to perform an operative wound exploration and washout. This deceptively innocent cut is actually the classic fight bite. Human oral flora is just incredibly nasty, and a whopping 75% of these wounds involve deeper cartilage, bone, or tendon injuries. You cannot just irrigate this in the ER. It demands the OR and IV antibiotics.
Let's apply that same vigilance to post-op care in MQ4. A 46-year-old woman is 3 days post-abdominoplasty. She's lethargic, hypotensive, tachycardic, and her drains have sanguineous clots. The most appropriate next step, a type and cross. Your brain should immediately jump to post-operative hemorrhage. Abdominoplasties create this massive dead space, and while pulmonary embolism is always on our radar post-op, this specific triad points directly to life-threatening bleeding right into that flap space.
On to MCQ 5. We have a polytrauma patient with a massive thigh wound, heavily contaminated with dirt and gravel. Following initial debridement, the best therapy is basic wet-to-dry wound care. Listen, heavy contamination absolutely contraindicates immediate definitive flap coverage or negative pressure wound vacs. No way. Instead, you need repeated debridements with wet-to-dry dressings until that infection risk drops to a safe level.
In MCQ 6, a 56-year-old man requires a full-thickness abdominal wall resection for bladder cancer recurrence in a previously radiated pelvis. Portions of the bilateral rectus abdominis will be removed. So, what provides the best reconstruction for this massive defect? The correct answer is pedicled antilateral thigh fasciocutaneous flaps. The reasoning here is just brilliant anatomic engineering. Component separation won't work because, well, the rectus is resected. The pedicled ALT flap brings in fresh, non-radiated facial and cutaneous layers to rebuild the abdominal wall, all without the need for complex microsurgery. MCQ 7 requires a little anatomical detective work. A 76-year-old post-CAB G patient has sternal dehiscence. Now, because the left internal mammary artery, the lima, was used for the heart bypass, the blood supply for left-sided muscle flaps, like the rectus or pectoralis, is just gone. You literally cannot use them. That makes the highly vascular pedicled omentum, combined with a skin graft, the safest and correct choice to cover that exposed bone.
Okay, MCQ 8. A 20-year-old suffers a gunshot wound to the arm, causing wrist drop 1 week later. How do we manage this? Treat it as a closed injury. Doing an EMG in the acute phase is completely useless. You actually have to wait 6 weeks to obtain baseline nerve conduction studies, repeat them at 3 months, and only then do you explore the nerve if there is no recovery.
For MCQ 9, what is an absolute contraindication to definitive flap coverage for a clean-appearing stage 4 ischial pressure ulcer? It's osteomyelitis of the ischium. You absolutely cannot place a healthy flap over infected bone. It guarantees the flap will fail. Sure, things like fecal incontinence or low iron are concerns, but they aren't absolute contraindications. The golden rule here? Always treat the underlying osteomyelitis first.
Wrapping up plastics with MCQ 10. A 42-year-old woman is 6 months post-fat grafting to her breasts and complains of right breast pain. Her mammogram shows bilateral lipid cysts in the upper poles, but linear calcifications in the right lower outer quadrant. The correct next move? A core needle biopsy of that right lower outer quadrant. The reason is that while bilateral lipid cysts and microcalcifications are totally expected, they're just benign fat necrosis after this procedure, the presence of unilateral linear calcifications with pain is highly suspicious for malignancy. You've got to distinguish expected surgical changes from cancer.
All right, we are pivoting sharply to our second section, Chapter 43. Here, we'll focus heavily on urologic emergencies, diagnostic algorithms, and trauma management tailored specifically for the general surgeon.
Starting urology with MCQ 1. A 72-year-old man had a single, now-resolved episode of hematuria. The next step? A complete urology workup. Urine culture, cytology, a CT urogram, and cystoscopy. Seriously, even one drop of blood demands this full workup to rule out malignancy. A simple non-contrast CT or ultrasound is just entirely inadequate here. In MCQ 2, a 45-year-old woman has a 6-millimeter left ureteral stone. Suddenly, she spikes a fever of 38.5 Celsius, and her white count jumps to 15. What's the best step? Get a urine culture and a stat urology consult for ureteral stent placement. This case brilliantly illustrates a core urology rule. An obstructing stone plus an infection is an absolute urologic emergency. Why? Because of the massive risk of rapid, fatal urosepsis. Antibiotics alone won't cut it. You have to urgently decompress that infected, obstructed collecting system.
Moving to MCQ 3. A 62-year-old guy comes in with acute urinary retention, low-grade fever, and on the digital rectal exam, a severely tender, boggy prostate. The likely diagnosis, bacterial prostatitis. The diagnostic reasoning relies on combining systemic and local signs. BPH can definitely cause retention, but without the fever. A standard UTI, you'd have a normal prostate exam. But a tender, swollen prostate combined with fevers drives the diagnosis straight to bacterial prostatitis, which needs empiric antibiotics.
MCQ 4 asks us to identify the false statement about priapism. The false statement is the idea that any form of priapism is a urologic emergency. That's just not true. We have to contrast ischemic and non-ischemic types. Ischemic priapism is a highly painful emergency that risks permanent erectile dysfunction, and it requires treatment with phenylephrine. But non-ischemic priapism, it's usually painless, semi-rigid, and caused by an arterial fistula from trauma. it is not an acute emergency. Okay, MCQ 5. A 35-year-old man comes in with a perianal abscess, but now he's got scrotal edema, an elevated white count, and a CT scan showing gas in the subcutaneous tissues of his groin. The only correct management here is immediate surgical exploration and debridement. The reason? This is Fournier gangrene, a deadly, rapidly progressing necrotizing fasciitis. You don't observe this. You don't just hang IV antibiotics or do a little bedside drainage. The second you see gas in the tissues, you are taking that patient to the OR immediately.
Let's look at trauma in MCQ 6. The statement is, most traumatic renal injuries do not require any surgical intervention. True or false? The answer is true. This might surprise some folks, but grade 1, 2, 3, and even most grade 4 renal injuries are managed non-operatively. We're talking bed rest, serial complete blood counts, and repeat imaging. You save the operating room only for patients who are hemodynamically unstable, have major renal vascular injury, or persistent life-threatening hemorrhage.
Finally, MCQ 7. A 25-year-old trauma patient has a shattered pelvis, perineal bruising, and he can't void. How are you managing this ASD? The sequence here is absolutely critical. First, obtain a retrograde urethrogram, or RUG. If that's negative, then you place a Foley catheter and get a CT cystogram. The reasoning? Never, ever place a Foley blindly in a pelvic fracture with urinary retention. The risk of completely transecting a partially torn urethra is just too high. You check the urethra with the RUG first. Once it's clear, in goes the catheter, and then you use a CT cystogram, not a regular urogram, to properly check for bladder rupture.
Well, we covered a massive amount of clinical ground today, from the recoil of a full-thickness graft to the strict sequencing of a pelvic trauma workup.
Okay, let's dive into this. Chapter 44, Obstetrics and Gynecology for the General Surgeon. All right, kicking off our first block of clinical surgery questions. These are those critical intersections between general surgery and OBGYN that the boards absolutely love to test. So, question 1 starts us off with ovarian cancer staging. The correct answer here is D, omentectomy. Here's the deal. Standard surgical staging for ovarian cancer is a very specific package. You've got to have pelvic washings, a total abdominal hysterectomy with bilateral salpingo-oophorectomy, or THBSO for short, pelvic and para-aortic lymphadenectomy, peritoneal biopsies, and, crucially, an omentectomy. Now listen closely because I want to warn you about a classic exam trap here. They're going to throw in options like splenectomy, bowel resection, maybe diaphragm stripping. And while those are totally valid for cytoreductive or debulking surgery down the line, they are absolutely not routine staging components. Do not fall for it. Just memorize this formula: omentum, washings, THBSO, nodes, and peritoneal biopsies.
Moving right along to question 2, a suspected adnexal mass. The answer is B, pelvic and transvaginal ultrasound. You know, in clinical practice, and definitely on the exams, an ultrasound is always your immediate first-line test for an adnexal or pelvic mass. It's fast, it's non-invasive, and honestly, it's incredibly effective at distinguishing simple cysts from solid masses. You really only escalate to advanced imaging, like a CT or MRI, if that ultrasound reveals suspicious or complex findings. Your memory tie here is super simple. Adnexal mass, ultrasound first.
Okay, question 3 tests your genetic associations. What genetic syndrome is associated with endometrial cancer? The answer is A, Lynch syndrome. So, Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, or HNPCC, is a massive systemic risk factor. And it's absolutely crucial to remember that Lynch is not just about the colon. I mean, yes, it significantly increases the risk of colorectal cancer, but it also spikes the risk for endometrial cancer, ovarian cancer, and a handful of other malignancies. Just lock this into your brain. Lynch syndrome equals colon plus endometrium.
For question 4, we're asked who needs an endometrial biopsy. The correct answer here is B, a 35-year-old with a BMI of 42 and daily vaginal bleeding. Let's break down the pathophysiology so it actually makes sense. Now, endometrial biopsies are standard for any postmenopausal bleeding or abnormal bleeding in women 45 and older. Right? But for younger women, it all comes down to risk factors. Obesity significantly increases the conversion of androgens to peripheral estrogen and adipose tissue. That unopposed estrogen basically skyrockets the risk of endometrial hyperplasia and cancer. So the memory rule to live by is young patient plus abnormal bleeding plus a major risk factor like obesity equals biopsy.
Question 5 brings up patient positioning for a pregnant patient undergoing surgery. Answer A is correct, supine with left lateral tilt. Let's trace the hemodynamic chain reaction if you get this wrong, because it's a big deal.
If a pregnant patient lies completely flat on her back, that heavy gravid uterus physically compresses the inferior vena cava. This compression drops venous return, which then tanks maternal cardiac output. Ultimately, this leads to decreased uteroplacental perfusion, causing maternal hypotension and fetal hypoxia. It's literally a disastrous cascade, and you can avoid the whole shebang entirely with just a simple left tilt.
Question 6 asks about the management of stage 2IB cervical cancer. The answer is C, radiation with sensitizing cisplatin. The absolute crucial concept to grasp here is that stage 2IB represents locally advanced disease. And once we're at this advanced stage, we firmly shift away from primary surgical resection. The gold standard treatment shifts to concurrent chemoradiation utilizing cisplatin. So, your memory hook for this one? Advanced cervical cancer requires radiation plus cisplatin, not a scalpel.
Now, what's really interesting about this slide is how cleanly we can organize these conditions for question 7. The question asks us to identify an incomplete abortion, which is answer B. Notice how an incomplete abortion presents with vaginal bleeding, an open cervix, and some retained products of conception. Compare that to the others. A threatened abortion has a closed cervix with a viable pregnancy. An inevitable abortion has an open cervix, but the pregnancy just can't continue. A complete abortion has a closed cervix with all products expelled. And a missed abortion has a closed cervix with a non-viable pregnancy retained inside. So for question 7, just remember, incomplete means an open cervix plus some products remaining.
All right, I want you to mentally shift gears for me right now. Take a deep breath because we are moving into Chapter 45, Biostatistics. We're going to slow the pacing down a bit to tackle some of these math-heavy formulas.
So, question 1 asks, which statistical test to use when comparing sodium bicarbonate versus no bicarbonate against the development of contrast nephropathy? The answer is C, the chi-square test, and here's the underlying logic. Bicarbonate is a yes or no variable. Nephropathy, also a yes or no variable. Because both of these variables are categorical, you'd plot them right onto a 2x2 contingency table. Anytime you're comparing categorical data to categorical data, it always points straight to the chi-square test.
Question 2 looks at albumopan and days until bowel function. The supplied answer key says C, ANOVA. Now, we really need to address the direct contradiction in the study material here. A t-test is specifically designed to compare means between exactly 2 treatment groups, assuming normally distributed continuous data. ANOVA, on the other hand, is used when comparing greater than 2 means. Despite this weird inconsistency in the source explanation, for this specific question, as it's written on your exam, you should follow the supplied key and answer ANOVA just to be safe. But keep the real rule in the back of your head. 2 means is a t-test, more than 2 means is ANOVA. Okay, listen up, because question 3 is a massive exam trap. The question is, if disease prevalence increases, what happens? The answer is D, sensitivity does not change. I'm going to repeat that because it's that important. Sensitivity and specificity are intrinsic test characteristics. They do not care about prevalence. However, predictive values absolutely do change. As prevalence goes up, your positive predictive value goes up and your negative predictive value goes down. Memorize this firmly. Prevalence changes predictive values, not sensitivity or specificity. Question 4 asks about the best study design for pseudomyxoma peritoneae. Answer A, case control study, is the right one. Pseudomyxoma peritoneae is a pretty rare condition. And when you're dealing with really rare outcomes, you can't just wait around prospectively. You'd be waiting forever. You have to take cases, meaning patients with appendicular cancer and pseudomyxoma, and controls, patients with appendicular cancer without it, and then look backward in time for associated exposures or risk factors. A rare disease practically mandates a case control design. Let's move to a data set for questions 5 through 7. We have 150 patients with lung cancer and 300 without. Let's construct our 2x2 matrix step by step. Out of the 150 diseased patients, 125 test positive, those are our true positives, and 25 test negative are false negatives. Out of the 300 healthy patients, 20 test positive, which are false positives, and 280 test negative are true negatives. Question 5 asks for sensitivity and specificity, and answer C is correct. Sensitivity is true positives divided by all diseased patients, so 125 over 150, which gives us 83.3%. Specificity is true negatives divided by all healthy patients, so 280 over 300, which is 93.3%.
Using that exact same data, question 6 asks for the positive predictive value, or PPV. The answer is A, 86%. And this brilliantly illustrates how entirely different PPV is from sensitivity. PPV essentially asks, of everyone who tested positive, how many actually have the disease? The formula is true positives divided by the sum of true positives and false positives.
That's 125 divided by 145, giving us roughly 86%. This gives us the real-world's clinical probability that a patient sitting in front of you with a positive test result actually has lung cancer.
Question 7 asks for the false positive rate. The answer is C, 7%. The standard math here is false positives divided by false positives plus true negatives, so 20 over 300, which is 6.7%, rounding up to 7. But, and here is a major time saver for the exam, use the alternative shortcut. The false positive rate is simply 1 minus the specificity. Since we already did the hard work in calculated specificity at 93%, 1 minus 0.93 gives you 7% instantly. Such a time saver.
All right, home stretch. Let's transition into our final chapter, Chapter 46, Patient Safety and Quality Improvement. Remember, these systems-based questions are guaranteed points on your exam if you just take the time to know the protocols.
Let's secure these points. Question 1 asks what we call a value plotted sequentially over time. The answer is B, a run chart. A run chart is honestly exactly what it sounds like. It visually tracks a metric chronologically across the calendar. Think about charting hospital infection rates from January to February to March. It's the absolute perfect visual tool to see whether a specific quality improvement intervention is actually succeeding or failing as time goes on. Just remember, a run chart runs through time.
Question 2 pairs value stream mapping with a specific methodology. The answer is C, lean. Think of the industrial origins of lean manufacturing. It is utterly focused on trimming the fat, eliminating waste, mapping out every single process, and relentlessly categorizing steps into either value-added or non-value-added buckets. So when you see value stream mapping on the boards, tie it immediately to lean methodology.
Question 3 describes a situation where staff repeatedly violate standard practice until it becomes viewed as completely normal. The answer is D, normalization of deviance. This is a critical, super high-yield behavioral concept in hospital safety culture. It happens when a deviation from protocol occurs repeatedly, without an immediate disaster, so people just get used to it. Eventually, the abnormal behavior effectively becomes the accepted cultural norm, which creates a massive, hidden safety hazard waiting to spread.
Question 4 asks about the model for improvement, and the answer is A, the Plan, Do, Study, Act, or PDSA cycle. The full model requires you to walk sequentially through 2 stages. First, you ask 3 baseline quality improvement questions. What are we trying to accomplish? How will we know the change is actually an improvement? And what change can we make? Once those are locked in, you launch the nested PDSA cycle. You plan the intervention, you do the test, you study the results, and finally you act to scale or adjust it based on what you learned.
Question 5 focuses on what to do retrospectively after an error or a near miss. The answer is E, root cause analysis. Now, unlike prospective tools, RCA looks backward to find latent system problems. You've got to march through 6 strict steps here. First, precisely define the problem. Second, construct a detailed timeline of events. Third, identify all contributing factors. Fourth, drill down to find the true root causes. Fifth, develop actionable corrective actions. And finally, sixth, monitor the results to ensure that error doesn't happen again.
All right, let's close this out with a rapid-fire sprint of the absolute highest yield facts from today. Ready? Run charts measure over time. Lean eliminates waste. RCA is strictly retrospective. Ovarian staging absolutely mandates an omitectomy. Adnexal masses get an ultrasound first. And please, whatever you do, do not mix up these 2 concepts. Sensitivity asks, if the patient has the disease, how often is the test positive? Positive predictive value asks, if the test is positive, how likely is the patient to actually have the disease? That distinction is one of the most commonly tested concepts in biostatistics, hands down. So I'll leave you with this provocative thought. When you're looking at your own study results, are you effectively measuring your true sensitivity to the material, or are you just hoping for a high positive predictive value on exam day? Keep studying smart, keep relying on structured visual recall, and I know you're going to crush this.